So guys, good afternoon. Welcome back to today's class. Once again, we are going to deal with the questions of T and D. And I need a quick thumbs up of whether it's audible or visible. Yes, can I go ahead? So guys, quickly we are going to learn about the carpal tunnel syndrome here. So I have already told you that there are various tests which are there to identify the carpal tunnel syndrome. So Pele, what is carpal tunnel syndrome? So which nerve is involved in this syndrome? Quickly your answers. So, carpal tunnel syndrome is a condition of where there is anatomical surface that is called the carpal tunnel, where the tendons of the hand enters, tendons of the forearm enters into. Understood? So here there is one important nerve which is called as the median nerve. So from this carpal tunnel, as you all know, there is this median nerve which is passing from the forearm into the hand, right? So as this is passing through it, superficial, it is just below the fascia. So skin, fascia, and then this median nerve is there. So whenever there is some volume constraints in this carpal tunnel, there is a pressure over this median nerve, and the patient will have symptoms of the will have the neurological symptoms such, such as tingling and numbness. Which area tingling and numbness will be present? For that, you have to understand what is the supply of the median nerve. The supply of the median nerve is to the 3.5 fingers, right? So these 3.5 fingers on the lateral aspect, that is thumb, the index, and the middle finger, these three, they will have tingling and numbness. Okay. Tingling and numbness over the 3.5 fingers of the median nerve, and then they may have this thenar eminence, weakness, atrophy, and all your tests could be positive. What are the tests we have discussed yesterday for the median nerve? So we have discussed various tests for the median nerve yesterday. So all this test could also be positive here. Okay. So that is how we diagnose this median nerve palsy. But before that, to confirm whether it is a carpal tunnel syndrome or not, which test we use? So what is this test? Is it clear now? Mohammed, hi. Okay, it is not audible. Okay, it is not audible. Okay, I feel everything is sorted now. Mohammed, is it clear from your end? Feel it is sorted from our end. Mohammed, just check your side net and all, no, your issues. Okay, now let's not waste much time. So now, what is this test? So now, till now, we have discussed about, what are the symptoms and signs of the median nerve. And before that, I just want to even tell you that what are the symptoms of the median nerve? How the patient presents to us whenever they have this problem of carpal tunnel syndrome. The first and foremost thing would be pain over the wrist joint and some discomfort in the wrist joint. They will not be able to, do their regular activity as they could do it in a regular basis. So that would be the main symptom. So they would come with pain over the wrist, and I've already mentioned that they would be tingling and numbness. So they would be pain with tingling and numbness. Okay. And then they will usually this pain aggravates at the night time. So there would be aggravation in the night time, and they whenever there is a flexion component involved, the pain increases. So what are all the areas where this flexion component is involved? For example, whenever they want to work on the laptop, so whenever you want to work on your laptops or your computers, you see you have to flex the wrist, right? And whenever they have to do cooking, there is also flexion of the wrist. So whatever the activities is associated with the flexion, usually in night time, what happens is whenever we put our hand over like this over the end of the bed, it goes into, so this flexion of the wrist will result in increase of the pain. So that is why patient usually complain pain over the night. And whenever there is this flexion component of the wrist, you will see that the patient has this increased pain. Why flexion increases the pain? Because flexion is one activity where again the carpal tunnel volume decreases. So this is the, whenever it is extended, the volume is, more, so it can accommodate more. But whenever the volume, whenever it is in flexion, it compromises the volume or the space, so there will be pressure over the median nerve and the symptoms will increase. So taking this as the advantage, they have designed various tests to identify the carpal tunnel syndrome. So one such examination or one such test is this. So what is this test? We have already discussed this yesterday. So I want someone to answer, what is this test? This could come as an IBQ. So what do you think is this test is? Name of the test. Quicker. So this is your phalanx test. So this is your phalanx test. So what is a phalanx test? A phalanx test is one whenever you do flexion of the wrist like this. So this will result or this will increase or aggravate the symptoms. So you can do this test directly in the OPD basis and see whether the symptoms have increased or not. So this is the phalanx test used for your carpal tunnel syndrome. And what is the other test? The other test, this is one test which we have learned. There is one more important test which is called as direct compression test. So can you tell me the name of this direct compression test? Direct compression of the carpal tunnel, that is direct compression over the median nerve, will produce the symptoms and you can diagnose it as the carpal tunnel. So what is the direct compression test called? Very good. I was just thinking about you, Nitin, and you have arrived. Okay. So that is called the Durkan's test. Very good. Thank you so much. So that is the Durkan's test. So this is the Durkan's test. So whenever you directly compress over that median nerve, so that is called as the Durkan's test. Understood? So this is the phalanx test and this is the Durkan's test. And one more thing yesterday we have discussed, we can also use the Tinel's the sign. So here we are checking the involvement of the median nerve. So Tinel sign also can be used as a method of diagnosing the carpal tunnel syndrome. Okay, then what is this? What is this test called? So a person is there, he's extending the neck, turning towards the same side of where the hand is being held. What is this test called? We've already discussed it. This is called the AdSense test. So this is the AdSense test and this is mainly used for the thoracic outlet syndrome. So what is a thoracic outlet syndrome? This is a condition where the what are involved? Thoracic outlet syndrome. So it is a small area where there is an outlet for all the vasculature or the nerve. So there is one vessel and one nerve, uh, or you can tell the lower trunk. So I've told you the answer. So C8 and T1 is usually involved here, and there is a subclavian artery which can get, involved in the thoracic outlet syndrome, right? So how do you test this thoracic outlet syndrome? So one test which we use, there are many tests, but the one test which we use, this is the AdSense test. So AdSense test, how you do? You turn your head towards the same side to extend it bit, okay, and then you will check for the pulses. So whenever there is a diminished radial pulse on this maneuver, whenever there is a diminished radial pulse, that is a diagnosis for thoracic outlet syndrome. So usually the lower trunk, so this is the lower trunk which is at risk, and sometimes you can feel the tingling and numbness in the little finger, right? So Between which two muscles is this structures present? So if you remember, there are scalene medius, scalene group of muscles. So in between which two scalene group of muscles are these structures present? So keep thinking about that answer. And now what is this test? This is one more IBQ. So these are direct IBQs. They can just put this image and they can ask you which test is this. The subclavian artery, Nitin, not the nerve. Yes, very good. This is the Allen's test. So this is your Allen's test. So what happens in the Allen's test? So Allen's test is used for what? So Allen's test is mainly used for the patency. So here the radial artery and the ulnar artery. Sorry, this is the radial artery and this is your ulnar artery. So these two have collaterals and they are supplying this hand in sync. So they have connections between your radial and the ulnar artery. So to check the patency of the radial and the ulnar artery, we do this Allen's test. Okay. What for ulnar and median? So this is for arteries, not for the nerves. For radial and ulnar artery. To check the continuity of these two arteries. So this is the Allen's test. So please remember that there are important tests. So one is your Adson's test for thoracic outlet, Allen's test for patency of radial and the ulnar artery. Phelan's test is directly for your carpal tunnel syndrome, and the Ober test is your iliotibial band. So what is this? This is your Ober test. So what is your Ober test? This is checking for your iliotibial band thickness. So sometimes the iliotibial band gets involved in some pathology and it will become so tight. So you have to check for that. So this is your Ober's test where the patient is allowed to sleep in a, if you're checking for this, for example, let's assume this is the right side and this is the left side. So the patient will sleep on the left thigh, and now what you do is you put your right thigh, you bring the right thigh outside the couch and you would leave it. So if it is freely falling down, then it is normal. But if it is stiff and if it is not falling down freely, that means there is an iliotibial tightness. Understood? So that is your Ober test. That is your Ober test. So whenever you're bringing your thigh outside the couch and you just leave it like that, it should freely fall. I mean, it should, because it is because of the gravity or because of the, it really falls. There is nothing to hold it. But whenever there's a tightness of that iliotibial structure, what is the iliotibial structure? It is nothing but the condensation of the gluteus muscle, right? Gluteus maximum muscles get condensed and it is forming the iliotibial band on the lateral aspect. So this iliotibial band, whenever it is tightened, it will not allow the leg to fall freely from the couch. Understood? So that is the iliotibial band tightness. Where do we check? By the Ober test. So these are the various tests which you have to remember. Understood? Is that clear, everybody? If it is clear, we are moving on to the next question. Okay, next question. 3-year-old boy is brought to the clinic by his parents due to frequent bone fractures. So there is increased frequency of the bone fractures, and here the age here is 3 years old. Minimal trauma. So this is very, very important. Even minimal trauma also is resulting in a fracture. Why this is very important? Why the word minimal trauma is important to us? So what do you differentiate between the word minimal trauma? So whenever somebody says that this is just due to a minimal trauma, what is the first thing which strikes your head? Yes, the answer is right, but I am asking you. Yes, very good. Hrishikesh, you are absolutely right. So, whenever they say that the trauma is minimal, but it has resulted in a fracture, that means you have to be very careful that we are dealing with a pathological fracture. We are dealing with a pathological fracture. That means the bone here is abnormal. So because the bone is abnormal, we are dealing with the minimal trauma. Even the minimal trauma is causing the fracture. But if somebody is telling that there is repetitive trauma, so if somebody is talking about repetitive trauma, what strikes your head? Repetitive trauma. Rishikesh? So there is repetitive trauma and that has resulted in a fracture. What does this mean? Yes, very good. It is a stress fracture. It is a stress fracture. And please remember here the bone is absolutely normal. Very important concept which you have to remember to diagnose between your pathological fracture and a stress fracture. So now I have told you the concept of pathological fracture and a stress fracture. Now this example of your pathological fracture here is your OI, osteogenesis imperfecta. Can you tell me the example of a stress fracture? Eponym of a stress fracture? Name of the stress fracture? Nathan, I think you can try. Yes, very good. It is March fracture. The example of stress fracture is March fracture. What you have to remember here is the trauma, the fracture has occurred because of there is repetitive, continuous trauma over the normal bone, which has resulted in a stress fracture. Whereas if the bone itself is abnormal, there is some pathology in the bone. That is why even a minimal trauma is resulting in a fracture. Now, the example here is osteogenesis imperfecta. But before arriving to that diagnosis, let us see what are the other clues which help us to even clearly understand that this is why. So one such example is blue sclera and hearing loss. So osteogenesis imperfecta is a triad. It is a triad where you see first there will be fractures, one related to bone, and then dentigenous imperfecta, that is teeth, and then there will be hearing loss. So this is a triad which you usually see in osteogenesis imperfecta, right? His parents mentioned that he had several fractures as, and genetic testing has also clearly mentioned that this gene, that is called 1A1 gene. This is a collagen gene which has been mutated. So this mutation is in the bone. So because you know that the collagen is very important structure in the formation of bone. So whenever there is some abnormality in the collagen, the bone would become weak. So that is why whenever there is minimal trauma, it has resulted in this fracture, right? So this is osteogenesis imperfecta. And what else you can see in osteogenesis imperfecta is this. So there are multiple fracture sites. So there you can see a fracture here, you can see a fracture here, you can see a fracture here, you can see a fracture here. So multiple sites there are fractures, and what you can see here, one more specific thing is the healing. The healing of the bone is normal. So healing, please remember, it is normal. So how many fractures would happen to the baby? It would heal normally. And whenever you take x-ray, you can see various stages of fracture healing. So you can witness various stages of fracture healing in this patients of osteogenesis imperfecta. Understood? What are these vertebrae? Can somebody remember what are the shape of this vertebrae in osteogenesis imperfecta? What are the shape of this vertebrae? Yes, very good. It is bullet-shaped vertebrae. Very good. You can see that there are bullet-shaped vertebrae in case of osteogenesis imperfecta. Okay. And what is this? So we have already mentioned that this is blue because again collagen, because of the abnormality of the collagen, there is a presence of the blue sclera in infants. So this is one such clue for diagnosing your osteogenesis imperfecta. Understood? So this is about your osteogenesis imperfecta. So what you have to actually remember is first the gene. So COL1A1 gene. So that is the collagen which is impaired here. So because of the collagen impairment, the bones become weak and they break easily. They break easily. So this is the deficiency in the organic matter. So if you remember the composition of the bone, I have already discussed yesterday also. So there is an organic component and an inorganic component, right? So organic and inorganic, right? So organic, there is a lot of collagen and other products, and inorganic is calcium and phosphorus. So whenever there is demineralization of the bone, that is because of decrease in calcium and phosphorus and vitamin D, which is the carrier for these two, the bones become, they try to bend, right? They try to bend, so they are easily deformed. But whenever there is a collagen deficiency, they become brittle. That means they're easily breakable. So please remember that whenever we are dealing with scurvy, whenever we dealing with rickets, the bone try to bend because there is a demineralization. So they can be easily deformed. Deformed bones are easily seen. But whenever there is an organic deficiency, like collagen is deficiency, they become brittle. So brittle means it is easy to break. So whenever you put trauma, they easily break. But whenever in demineralization, they try to bend. So that is why when you see this thing like frequent bone fractures, you can curvy and rickets, you can easily eliminate. So we know the concept that that is because of the demineralization, the bone where the bones easily bend. In osteogenesis imperfecta, because the organic matter is weak, they become brittle and they tend to break. Understood? Achondroplasia. Now let's just discuss about achondroplasia. And one more thing I want to add about this osteogenesis imperfecta, sheikh kebab. What is this sheikh kebab? Sheikh kebab. I think Muhammad has to answer this. Sheikh kebab. Yeah, your von Dever-Hip syndrome also is the same. The triad is your von Dever-Hip syndrome. That is blue sclera with your hearing loss and a breaking of the bones. Now, what is this sheikh kebab? It is very interesting. You want to try? Guess? Rishikesh? Nitin? No idea. So I will tell you. So how do you treat the osteogenesis imperfecta? So whenever it is infants, no, what do? We can't do anything. We will try to wait. But once when these people have this multiple fractures in a bone, so what we do is we put an intramedullary nail along all these bones. So this looks like the famous dish which is called the sheikh kebab. If you go to the restaurant and if you see, if you order sheikh kebab, they will put this pieces, the meat pieces over one big rod. Have you gone to barbecue? So that is called the sheikh kebab surgery. So because they have multiple bone pieces, they pass through the intramedullary rod to it, and that is called the sheikh kebab surgery. So this is called the sheikh kebab surgery. And there is one more rod you have to remember, that is dual rod. Dual rod is intramedullary rod where it can increase. I mean, like it is expandable rod, because usually we treat in kids, right? We treat in the children, right? So this is dual intramedullary rod which is expansile, which expands, and this is the sheikh kebab surgery which is used in osteogenesis imperfecta. Because of its terminology, sometimes they can ask you in the exam. Is that clear? Clear, guys? Okay, fine. That is about your osteogenesis imperfecta. Now moving on to the achondroplasia. So as you know, achondroplasia, A and chondro is not something which is again related to the bone. So chondro is nothing but cartilage, right? So there is some deficiency in the cartilage where the growth of the bone is arrested. So there will be growth of the bone is arrested at a faster rate. So these people will result in what is called as dwarfism. So the length, the bone length, because the length of the bone is by the growth plate, right? And the apophysis is by the circumference of the, you remember this, right? The length of the bone is by the physis. So physis is nothing but the growth plate. The apophysis, what is by the apophysis? Apophysis, you get the circumference. The diameter of the bone is by your apophysis. So this has to be correct so that you will achieve that necessary length. So whenever there is an abnormality in achieving the length which is leading to dwarfism is called as achondroplasia. This is again because of the mutation in this particular growth factor, that is fibroblast growth factor gene, that is FGFR3 gene. So because of that, what happens is there is a disproportion in the disproportionate growth is seen. So limbs are short, your abdomen and your the other body is longer. So limbs appear to be shorter. Because of that, the height is not achieved and the patient appears to be in short stature. So this is the short stature. And one more interesting feature is they present with the trident or the starfish hand. So trident or the starfish hand. And what you have to remember is the mental IQ, that is the IQ is normal in these kids. So normal IQ is there, only problem is with the attainment of the length of the limbs, the upper limbs and the lower limbs. They don't attain the length which is required for them. And what you have to remember is there is a mutation in this FGFR3 gene, FGFR3 gene that was called 1A1 gene. This is FGFR gene, and the two important thing is the stott stature and this trident hand. Is that clear for the achondroplasia? Yes, that could sometimes be true. Upper segment will be more than the lower segment, because the upper segment, again, you have to make sure that this is the upper segment which includes the chest and the abdomen. Again, the hands will be short, and lower segment mein limbs will be short. So wherever the limbs are present, that is your arms and the your legs will be shorter compared to your body. That is this body, the upper body. Okay. That is about the achondroplasia. So now we have dealt with the osteogenesis imperfecta, scurvy and rickets. We have already dealt in the first question, and now we have completed the achondroplasia. So no confusion. Any question from this chapter you have to answer. Fine. Now let's move on to this interesting topic again. So now match it as fast as you can. So this is my answer. Have you all answered this? So what is the answer? 1D, 2C, 3A, and 4B. I think B is the answer. B, everybody with me? B is the answer. So now let us learn few important terminology. D, yeah. A, B, D. See, the two options are same, no? B and D. Okay, we'll give. B and D both are correct. DCAB, DCAB. Yes, yes, Nitin, you're right. See, both options are same. B and D both are same. Okay. Hmm. Now let's learn about the tennis elbow. So what do you think is tennis elbow? As you have already matched it right, this is lateral epicondylitis. So again, the lateral epicondyle, whenever it gets inflamed, this is called as the lateral epicondylitis. Itis का मतलब क्या है? Itis is nothing but your inflammation. So whenever there is an inflammation, all your tumor, duller, rubor, calor will come in. So that is nothing but pain will be there. Then they will have redness, then they will have mild swelling, and then there will be heat, warm. Okay, so all the symptoms patient will come and tell you. But now what is your treatment to it? So you have to analyze what is actually happening in the tennis elbow. So the problem here starts with, because this is a common extensor origin. So this is a CEO, where all the extensor tendons take an origin from this common extensor origin, which is the lateral epicondyle. And in that, in particular, you have to remember that the extensor carpi radialis brevis tendon is one which is the main culprit. So ECRB, extensor carpi radialis brevis. So this is the tendon which is actually the target for the treatment. Okay, this is the target for the treatment for tennis elbow. So what is the treatment? So first, what you do, any orthopedic, first you always start with rest, because this is mechanical. You use a lot of hand. What are those maximum hand movements which we use? We use squeezing, twisting, driving, and then a lot of, computer work. So all that has caused problem. They caused inflammation of the tendon. So first you tell the patient to take rest, and then you treat with the NSAIDs, because this reduces the inflammation, so the pain is reduced, right? And then we can apply tennis elbow brace, and then you can also treat with a dose of steroid. Now PRP is also being used in treatment. These are all the treatment options for the tennis elbow, that is lateral epicondylitis. And before that, what is the most important thing, exam point of view? So this is all your clinical knowledge, but for us to practice clinically, we need to pass the exam, right? So how do you test the patient who has come to the OPD that this is actually the tennis elbow? So what is the test? What is the test we do for tennis elbow? Quicker. Rishikesh, name of the test? It is easy actually. You have to remember. Air pickup, Cosen's test. Cosen's test is the test which is usually done for for diagnosing the condition which is called as the tennis elbow. Understood? So how do you do this Cosen's test? So Cosen's test, now what you do is you try to extend the wrist, and whenever you try to extend the wrist, you ask the patient to ask the patient to try, tell her to extend the wrist, and that is against resistance which is given by the surgeon or you. And whenever you're doing this extension, what happens is the patient will feel pain in the lateral epicondyle, and that is called your Cosen's test. That is called your Cosen's test. So this Cosen's test is your lateral epicondylitis. That is nothing but your tennis elbow. And everything is same for the medial epicondylitis. So medial epicondylitis same. So इसमें क्या होता है? Medial epicondyle is at the wrist. And what is the test for this? Test for medial epicondyle. I mean medial epicondylitis. Nitin, share drop now this time. So this is reverse Cousins test. So this is reverse Cousins test. So similarly, like there you are doing extension, here you yeah, it is golfer's elbow. Very good. Golfer's elbow test. Okay, fine. So that is again you will do for the flexion of the wrist. So you do the flexion of the wrist and then the patient will have pain. So that is your medial epicondylitis. Then what is nursemaid's elbow? Nursemaid's elbow. Nursemaid's elbow. So this is typically, yesterday we have spoken about some dislocation and subluxation. So this is the radius or the radial subluxation or the radial head which comes out of your annular ligament. So this is annular ligament is something which is round in structure and which contains your radial head. So this is your radial head, and now what happens is there is an annular ligament which is present around it. So this typically occurs in kids. This is not elbow dislocation, Nitin. So you have to be very clear in usage of your term. So this is not elbow because elbow joint is formed by elbow joint is formed by which two bones? Elbow is formed by your ulna and the humerus, right? So radius will just act as a support. Radius. What is elbow joint? Ulna, olecranon process, right? Olecranon will get attached to the olecranon process of the humerus. So the ulnohumeral joint is your elbow joint, right? Ulnohumeral joint. So now this, you can't tell this as elbow dislocation because this is just the annular ligament. So you already know that this is the ulna, and here, somewhere here, you will find the radial head, right? So this is the annular ligament, and here this is the humerus. So this is not elbow dislocation. Ulna and humerus is your elbow joint. So this is just radial head subluxation, and not, and again to remember, it is not complete coming out of the radial head. It is just slightly coming out. That is your radial head subluxation. And when this typically occurs, it usually occurs in kids, some 4 to 8 years. Not 4 to 8 also, it is less than some 5 years of age. Less than 5 years of age. Okay, less than 5 years of age, and usually the father will be the culprit, if you remember. And now what happens is this father wants to play with the kid and he will hold the kid's hand like this, and the kid will be standing like this. So whenever they're holding the hands very, and they're pulling the hands with full extension, they completely pull the hands. Now what happens is this radial head, that it gets slips of this annular ligament. And now what you do? This is we treat this as an emergency because this is again a subluxation. So subluxations or dislocations should be treated immediately. So what you do? You will try to flex the elbow and then you try to supinate. So this flexion and supination is done. Then you will hear this click sound. So that radial head goes back into that ligament and you will hear this click sound and the patient will suddenly stop crying. right? So this is very, very commonly seen in the OPD with the kids. So this is nursemaid's elbow, and in this what happens is only this radial head will come out of the annular ligament, and now with this maneuver of you flexion of the elbow and then you try to supinate, the radial head will sit into the annular ligament and child immediately will stop crying. Okay, so that instant gratification you get with the treatment of this. Okay, so this is also is an emergency. And then the final one is your student's elbow. So student's elbow, what is it? This is nothing but your olecranon bursitis. So like students, you keep watching the teacher and now you try to listen to the lecture with your hand like this on the table, right? So whenever you're putting your hand on the hard surface, so because of that friction of the olecranon, because that is a bony structure. So there is some bursa which is present around the olecranon, and that due to constant rubbing that results in the inflammation of the bursa, which is called as the student's elbow, that is olecranon bursitis. Clear everything? Right? Okay. Rishikesh, no answer from you? So that is about the various structures which we see around the elbow, right? And now there is one more question waiting for you all. So this is a case of a 14-year-old came for a routine checkup. During the physical examination, you have noticed there is an asymmetry in her shoulder heights and a prominence of her right scapula when she bent forwards. And now we are suspecting scoliosis. Which of the following clinical test is mostly to assess the scoliosis in this patient? So scoliosis is one more important topic. So scoliosis is frequently asked in the exams. And what is scoliosis? This is nothing but there is a bend in the spine. So usually the spine is a straight structure starting from the cervical spine to the coccyx. It is a straight structure. But whenever there is some abnormality and it is trying to bend sideways, so if it is straight like this is normal spine. But there is some abnormality and it is becoming in S shape. So this is called the scoliosis. So there is a curve which is happening. So this is the curve. So there are again two types of curve which you have to define, the primary curve and the secondary curves, right? So you have to tell us which side it is bending. Is it bending on the right side? It is bending on the left side, like that. So that is the terminology of the scoliosis, and it can appear in any part of the spine. If you remember, cervical, thoracic, lumbar. So it could be thoracolumbar scoliosis or only thoracic scoliosis, lumbar scoliosis, like that. So that is about the scoliosis. So this is what I was talking about, the sideward bending, the curvature like this. Okay. And now there are certain tests. So this scoliosis can also occur, this sideward bending can also occur as a compensatory mechanism of the hip joint pathology. So whenever this hip joint is connected to the spine, so if you see, these are the hip joint and this is the spine in center. So there is some problem in the hip joint also, they will be bending in the spine. Is that clear? So now what do we call this as the secondary scoliosis? Okay, or this is called as compensatory scoliosis. Compensatory means problem in the hip joint, right? Problem in the hip joint, but the spine is bent. Problem in the hip joint. Now you see scoliosis in the spine. So there is no problem in the spine actually, because of the hip joints are not proper, because they are all connected. So this is the two hip joint which is connected, and now this is your spine. So because they're connected, so any problem in the two hip joints also will result in scoliosis. So that is called secondary or compensatory scoliosis. But if the problem is in the spine, and then you see scoliosis, this is called primary scoliosis or structural scoliosis or pathological scoliosis. Is that clear? Is this terminology clear for you? So now you have to differentiate between it is whether this was a structural scoliosis directly, the scoliosis is because of the problem in the spine, or because the problem is in somewhere else, like the hip joints, we have mentioned it. So for that, what is the test we do? Yes, very good. It is the Adam forward bending test. So why this, by this bending, what happens when this bending, what will happen? So on this bending also, if the scoliosis is still present, then it is the structural scoliosis or pathological scoliosis. On bending, if the scoliosis is absent, then you cannot see scoliosis on bending. That means it is a compensatory scoliosis. So this is what we do. This is called the bending. So a person is having scoliosis. Now you ask them to bend. So that means what you're doing, you're causing the flexion of the spine. On flexion, if the scoliosis is present, then it is a structural or a pathological scoliosis. If on the flexion of the spine, scoliosis is absent, bending is absent, then it is called functional or compensatory scoliosis. Functional or compensatory scoliosis. So this has been given by Adam, and this is called, because we are asking them to bend, so this is called as Adam forward bending test. Is this clear? Rishikesh? Yes, good. Then what is this? Again an IBQ? Very good. This is Roos test. This Roos test. So used for Roos test is used for diagnosis of. Very good. Thoracic outlet syndrome. So we have learned one is the Adson's test, which is very, very specific. The second one is Roos test. Roos test, what do? You put your hand like this, 90 degrees of flexion of the elbow and the shoulder, and then you constantly do this maneuver where again you will feel diminished pulses on the side affected. So this is also a test for your thoracic outlet syndrome, and this is your Adams forward bending test. So this is your Roos test, and this is your Adams forward bending test. And what is this angle? This is angle for scoliosis. So what is that angle called? So here first you will identify the curve from where it is present. How do I identify? You will take this vertebrae. So you will observe this vertebrae. So if you see this vertebrae straight enough like this. But if you see this vertebrae will slightly be converged. So the posterior will be more, the anterior will be less. So these converged vertebrae we identify, and the most corner vertebrae we take for the curve, and we draw lines like this. So we are measuring this angle, right? So this is called the, very good, this is called the 𝐒𝐄𝐝's angle. This is called the 𝐒𝐄𝐝's angle or scoliotic angle. So this is mainly used for scoliosis. Okay, and what is the normal angle? 𝐒𝐝's angle. So 0 to 20 degrees, 20 to 40 degrees. Why you want to actually measure this 𝐒𝐝's angle? Measure the 𝐒𝐝's angle because you want to know how to treat the patient. So whenever a patient comes to you and now you, because for some time what happens is the Adams forward bending test may, what happened is it has come out as it is a structural scoliosis. That means there is a problem in the patient, that is problem in the spine. Now the patient will ask you what is the next step, then what you will tell her. Now what we do is first we try to see the age of the patient. So why do you want to see the age of the patient, and what is the important sign related to age of the patient? In case of scoliosis, where we take the help of the iliac apophysis, what is the sign called? So two important things you have to learn in case of scoliosis. So one is the angle, because this has been recently asked in the exam, and this is also useful for clinically also. So we are learning about the 𝐒𝐿𝐵's angle, and we have learned that this angle will tell us something related to the treatment. So we are learning this angle because we will know how to treat the patient based upon this angle. So if it is 40 to 60 degrees, we know that this patient is going for surgery. And if it is 20 to 40 degrees, we will take the patient with orthosis, that is the braces. The braces for the treatment. And if it is 20 to 10 to 20 degrees, we can wait and watch. But what we are waiting, and how long we wait and how long we watch. So for that, we have to know the age of the patient. And here I have given a clue that we are going to use the iliac apophysis to understand the sign. There is one sign which will tell you whether the patient has attained his maximum growth. Why you want to know the growth? Because you know that this curve will stop when the patient will attain the maximum growth. So if the patient angle is 20 degrees here, then you can still wait, because if the patient has attained the maximum growth, that is 18 years of age, 19 years of age, so you know that the growth, uh, this curve, the scoliosis curve also keeps growing with the growing age, right? So whenever it stops, whenever the curve stops, then only we tend to treat the patient, right? So if that curve is around 20 to 40 degrees, and if the patient is around, 17 years, 18 years, 17 years, 18 years, then you will try to take the research sign. So you will try to take the research sign. So research sign is nothing but this is the iliac apophysis. We see how the iliac apophysis is formed. So there are stages 1, 2, 3, 4, 5. If it has reached the fifth stage, that means it is completely mature skeleton. Understood? So it is a completely matured skeleton. So if it is in stage 1 or 2, you can still wait for the patient to grow, and then you can start the treatment. So that is the two important things we actually have to remember in scoliosis. So one is your 𝐒𝐿𝐵's angle, the second one is your research sign. Is that clear? Archana has only come to tell Nitin hi or for the class? Okay. Is this clear? So this is very, very important. And whenever somebody is asking about the 𝐒𝐿𝐵's angle, because they have asked enough times of what is 𝐒𝐿𝐵's angle, now this time they might ask you how it is helping. So they can put up a 30 degrees of scoliosis and they can ask you the treatment. Uh, they can ask you the treatment. So whenever they're asking you somewhere related to angles, you have to be very clear that if it is 20 degrees, it is nothing that you can wait, and you can explain the patient that you need some more. That it is okay. The body is about to, the body is able to take this angle, and you can just wait and watch. If it is increasing, then you can go for braces. So if it is 20 to 40 degrees, you are going to use orthosis, I have told you. So what are these two important braces which are used in case of scoliosis? So what is this, Archana? What brace is this? So if you have just come, you should tell hi to me, no, not to Nitin. What is this brace which is used for treatment of scoliosis? I have told you the 20 to 40 group angle. The name of this brace, very, very important. They keep asking you as an IBQ. This is again an IBQ. Denny? No, this is Milwaukee. And what is this? This is Boston. So remember, Boston is something like this, like a. No, this is Boston brace. Okay, this is Boston's brace. Yes, you're right. That is Milwaukee brace and this is Boston brace. And these two braces are used in case of scoliosis and it is very, very important exam-based question and these are image-based questions, very, very important. Okay. So one is Milwaukee brace. The second one is your Boston's brace. Is that clear? So this is about the scoliosis. So this is all you have to remember regarding scoliosis. So first starting with the Adams forward bend test, then we have dealt with the Cobb's angle, then we have dealt with the braces and the research side. Okay, what is Schober's test? Schober test is used for in which you use Schober's test. Which condition we use the Schober's test? So Schober's test we use in the ankylosing spondylitis. So ankylosing spondylitis is the condition where we use the Schober's test. Yesterday we have dealt with it. And Allen's test again for the patency of the ulnar artery and the radial artery. And then Roos test we have already again learned here that it is for thoracic outlet syndrome. So thoracic outlet syndrome. So this is about the various tests again. Moving on to the next question. A 65-year-old female presents with history of progressive back pain and a recent vertebral fracture after minimal trauma. So again, if you remember minimal trauma, so this is again a pathological fracture. So here the pathology is, so we will wait for some more clues to understand what pathology is this. So she has risk factors for osteoporosis. So there are various risk factors such as, where there are certain risk factors which you can ask for the patient. And this patient has this risk factor for osteoporosis. And there's a family history on long-term corticosteroid use. So this is one of the most important risk factors. So whenever the patients are on steroids, they tend to lose the bone mineral density, which will result in the osteoporosis, right? So steroid usage can lead to osteoporosis. And what is the investigation to diagnose osteoporosis in this patient? So one such investigation which can directly lead you to osteoporosis diagnosis. So here, usually the serum calcium and vitamin D levels would be normal in this condition, right? And then we use this DEXA scan for diagnosing the patients of osteoporosis. So what is DEXA scan? Yes, very good. It is DEXA scan. What is DEXA scan? It is dual energy absorptiometry. So we use this DEXA scan, and this is nothing but we use same X-rays at a lower energy, right? So this X-ray are used to take the calcaneum or vertebrae or the wrist, and this is used for evaluation of your bone mineral density, and these are compared to the T scores and the Z score. So I think you are even more aware of what are T scores and Z scores than me, because they will teach you in detail in your SPM classes. So what is a T score, what is a Z score? But here what we use is mainly the Z score for the diagnosis of the DEXA scan. So in the Z score, if it is less than minus 2.5 times of the standard value, then the patient is suffering from osteoporosis. So minus 2.5 is the cutoff, and if it is minus 3, then it is severe osteoporosis. Is that clear? So osteoporosis is diagnosed by one such investigation, which is called as DEXA scan. It is dual energy X-ray absorptiometry. So that is about the DEXA scan. And how do you treat it? So what is the treatment for your osteoporosis? This is very, very important. Usually they treat, they usually ask you in case of pharmacology, but as a completion sake, this is discussed. So you treat it with, again, your vitamin D, calcium, a basic, and then calcitonin. Then you treat with bisphosphonates. So what are these bisphosphonates? What are the bisphosphonate? What they do? And yesterday we have also discussed denosumab. Okay, what is osteoporosis? Osteoporosis is a condition where there is an increase in osteoclastic activity. So osteoclastic activity means what is happening? So bone resorption is increasing, right? So there is an increase in the resorption, decrease in the formation. So what you have to do? Now what you do is you try to increase the formation or you try to decrease the resorption. That is the only thing which we can do. So this is what is happening. So whenever there is an osteoporosis pathology is happening, that is nothing but there is an increase in the resorption of the bone. So decrease in the formation, increase in the resorption. Whatever treatment we do, we try to reverse it. So what we try to reverse it, we increase the formation of the bone. So this is by the calcitonin or the parathyroid hormone, which will increase the formation, right? And resorption is increased by the bisphosphonates. So these bisphosphonates, this denosumab, what will do, it will decrease the resorption. It will decrease the resorption. But there is one such drug which will do both. What is that drug? This drug will do both. That is, it will increase the formation and decrease the resorption. So which drug is that? What is that drug? So that drug is your strontium. Strontium ranelate is the drug which is doing both. So all this other treatment, what I've told you, will either increase the formation or decrease the resorption so that the bone mineral density is maintained. But strontium ranelate is one such drug which does both the action. So it increases the formation of the bone and decreases the resorption of the bone. That clear? So that is regarding your osteoporosis, and we can even go for CT scan of pelvis for identification of the fractures. So what are the areas where there are risk for osteoporosis fracture? Teriparatide is nothing but your parathormone, right? PTH. So I'm asking about what are those common fractures where you see in people suffering from osteoporosis. Yes, fine is a very vague answer. You have to tell it is thoracic vertebra. So thoracic vertebrae are the areas where usually we see the fractures. Next, very good. The wrist joint, distal radius, and then your hip. That is your IC. So you have to be very specific in your answers. So one is your thoracic vertebra, the second one is your distal radius, and third one is your intracapsular. Right? So these are the areas where you have to check whenever you have doubt for a patient suffering from your osteoporosis. Right? So these are the fractures. These are fractures of the areas. Right? So that is about the osteoporosis. Okay? Now then this is very interesting. Quickly answer. A 79-year-old patient with the history of fall X-ray was taken, diagnosis, and choose the best management for this patient. So what could be the best management for this patient? You either go for a bipolar hemiarthroplasty or a intramedullary nail or a hip spica or internal fixation with a DHS, which is nothing but your dynamic hip screw, or a PFN, which is nothing but a proximal femoral nail. Very, very important. It has been asked recently in the NEET PG twice. I mean, the same question was put up in different form. Two questions from this concept has been asked in NEET PG recently. So there is a high chances for you all. You know, there is a high chance for all for the FMG students also. So now let's clear this concept of what is the choice of implant for this fracture. So first identify what fracture is this. Now Nitin, don't type it as hip fracture. What fracture is this? Name of this fracture? So always whenever you're dealing with the hip fractures, you should always remember in mind we are dealing with two type of fractures. One is the IC fracture, that is intracapsular fracture, and the second one is IT fracture, that is the intertrochanteric fracture. So this IC fracture, whenever I talk about this is where the femoral head is separated from the neck. So there are high chances of the AVN. Hence, we always go for hemiarthroplasty, meaning plasty meaning joint replacement. Hemi means half. So we are replacing a half joint. That is, femoral head is replaced by a prosthesis, which is called as the bipolar prosthesis, which is called as a bipolar prosthesis. Whenever I'm talking about the IT fracture, it is the intertrochanteric fracture. So a trochanter region is fractured. So there is no risk of AVN is less. Hence, we treat with what is called as a dynamic hip screw or the proximal femoral nail. This is open reduction internal fixation. So both of this will use under the C arm, right? So we use the C arm, which is nothing but the X-ray which is present inside the OT. So that C arm we use and we fix it with the dynamic hip screw or the proximal femoral nailing. Is this clear? Now identify this. What is this? What is this? What is this structure? I mean, not structure, what is this implant? X-ray. This can also be an IBQ. They will just put this image and they will ask you identify the implant. 1, 2, 3, 4. So which implant do you think this is? No, no, don't go such fancy, Nithin. This is a simple DHS. This is dynamic hip screw. So you can see there is a screw inside the head and there is a plate. So whenever you see, this is called the plate and this is the screw. And this is fixed, this plate is fixed to the bone by the cortical screw. So this is the head screw and these are the shaft screws. And this is called the dynamic hip screw. So whenever you see a screw with the plate, so this is, there is a head screw plus a plate. This plate is fixed to the bone by the cortical screws. Okay, so this is a dynamic hip screw. Fine. And then what is this? What is this? Identify this implant. So here, if you see, you can see this is a fracture line, right? This is a fracture line. And if you see this particular X-ray, and this is the fracture line. So what they will do is first they will try to reduce it on the fracture table. So we have a separate table for this that is called the fracture table. And once we achieve the reduction, we will pass this nail and not completely opening the fracture. We will just try to pass this nail and we will try to put these two screws and this screw in the shaft, and this is called as PFN. This is called the proximal femoral nail. Understood? Yeah. Okay, TFN. So I want to tell Nitin one thing. So now, before they used to use this proximal femoral nail. So in this proximal femoral nail, what you see is there are two screws. If you see, there are two screws, like one short and one long. This was the older version of PFN. Now the recent version is TFN, that is trochanteric femoral nail, where we use only one screw in the head. So whenever you see this one screw in the head plus nail, then you have to answer this as your TFNA. What you've been answering, when you see there are two screws in the head and then with a nail. See, this is a cephalomedullary nail. Cephalo matlab screw in the head, right? And then you see a nail, right? So this is called the proximal femoral nail. When you see only nail like this, only nail like this, and there is no screw in the head, then this is called as the intramedullary nail. Don't get confused, my dear children. So intramedullary nail is one nail where you don't see any screw in the head, right? So whenever you see the screw in the head, then it should either be with the plate. When you see a plate, you name it as DHS, and when you see a nail, you may name it as PFN. Understood? So this is DHS or PFN for the treatment of your intertrochanteric fractures. Then what is the treatment of IC fracture? So what is this? So here, if you see, we have completely replaced the head with the prosthesis. So in the olden times, they have been using the Moore's prosthesis, then they have been using the Thompson's prosthesis, but the shift now we have been shifted to what? A bipolar prosthesis. So again, identification of the Moore's prosthesis, the two holes, right? You have to remember that way. So you can see there are two holes in the prosthesis. So here similarly, you will have two holes like this. So this is a Moore's prosthesis if you want to identify. If you want to identify Thompson's, you will see there will be a collar like this. So there will be head similarly and there will be a collar on it. So that is called Thompson's prosthesis. But if you only see a head with a stem like this, which is, small and sleek, so this is a bipolar prosthesis. So this is a bipolar prosthesis. So it has dual movement. So your Moore's and Thompson's only one movement, that is between the acetabulum and the head. But if you see bipolar, that means your acetabulum and the head there is movement, and between the head and the neck here there is one more small thing which is present here. So the movement is present between those two also. So that is why this is called as the bipolar prosthesis. And now usually we are using this bipolar prosthesis. Okay, is that clear? And now if you see similarly, if you see this acetabulum is also replaced. So now, for example, if this acetabulum is also like this, replaced, then what is that called? So here this is only the head which has been replaced. But even if the acetabulum is replaced, then you call this is total hip replacement. So these are the treatment for above 60 years IC fracture. Then you have to ask me what is below 60 years treatment. So whenever there is something related to IC fracture, age is very, very important. right? So if it is 60 years, what you go is for osteosynthesis. That means you will not replace the head, and you will try to fix the head with the 3cc screws. What are these 3cc screws? That means these are called the cannulated cancellous screws, right? In the figure of 3, in an inverted triangle fashion, right? So this is application of the CC, application of the CC screws in the head. Similar, like instead of this, instead of the replacement of the head, what we do is we put the head in that place and we'll try to fix it with the cannulated cancellous screws. So these are like this. So there are threads like this, and so we put. So now the head will heal. So that is called osteosynthesis. So we are promoting the formation of the bone in the femoral head. That is why this is called as osteosynthesis. Whenever there is an IC fracture of less than 60 years, if the patient is less than 60 years, or usually in the middle age, that 20 to 40 years, we go for this osteosynthesis. If the patient is more than 60 years, and if the acetabulum is also damaged, sometimes for IC fracture, then we go for THR. So don't get confused if there is an option of total hip replacement also. Read the question properly. Okay, if their age is more than 60 years, if the patient is normal, if it is actively walking before the fracture, then you can go for any of these options, but you have to check for acetabulum also. If the acetabulum also to be replaced, that means there is some arthritis in the acetabulum, then you can go for a complete hip replacement at one go. Or else you can treat her with bipolar prosthesis if the acetabulum is good, and then you can ask her to come back for THR. But if the patient is less than 60 years, that's somewhere in 40, 50 years, then you can try for osteosynthesis, where you use 3 screws, that is cannulated cancellous screws. Why the name cannulated? Because there is a gap in this, so that you can put the guide wire first, and over that guide wires you can fix these screws. So this whatever the screw is there, there is place for us to pass the guide wire. So that is why this is called as cannulated. So there is like cannula like thing. So you put a guide wire first into the femoral head, and over that guide wire you will send the screw. So it is a cancellous screw and there is a cannula. So that is why it's called as CC screws, the cannulated cancellous screws. Okay. And how they are put? They are put in this inverted triangular fashion. This completes your complete questions on IC fractures, your IT fractures. Okay, very important. Is this clear? Good. What is this? Again an IBQ. Tapendra, what is this? Rishikesh has left. Yes, this is a Taylor's brace. So we already know what is Milwaukee brace scoliosis. We already know what is Boston's brace. And where is this von Rosen splint used? Which condition is this von Rosen splint used? Faster. Yes, very good. It is used in DDH. So von Rosen splint is used for kids in case of DDH. So the answer here is Taylor's brace. So this Taylor's brace is mostly used in case of tuberculosis of the spine. So whenever we encounter tuberculosis, because this is a thoracic area and this thoracic area is stabilized by this belt, this is called as the Taylor's brace splint. And Milwaukee and the Boston is used for your the scoliosis, right? And von Rosen splint is for DD. Is that clear? Then this is very, very easy. We have already discussed this. For diagnosis of the shown images, Klippel-Feil syndrome. So we already know that there is a low posterior hairline and fused thoracocervical vertebrae, and then there is a decreased cervical movements. These all contribute what is called as the Klippel-Feil syndrome. So we have already dealt with this. And now, what is this? A 30-year female has backache, which is radiating to the right lower limb. Below, this is MRI picture attached to what is the most common nerve root which is involved. So answer for this? Yes. So if you see, this is a S vertebrae. So this is the sacral, L5, L4, L3 and L2. And clearly they have given us an arrow. There is a block in the flow. So there is a disturbance in what is called as the L4, L5 vertebrae or the disc. So this is nothing but the L4, L5 disc prolapse. And whenever there is L4, L5 disc prolapse, which nerve gets involved? Is it L4 or L5? So now before that, we have to understand what is a disc prolapse. The sciatic nerve only, but is it L4 or L5? So this is the basis for your disc prolapse. So what is disc actually? So if you see the disc, this is what? This is nucleus pulposus. This is a remnant of the notochord, which is the nucleus pulposus, and this is being covered by the annulus fibrosus. So this is a ring-like structure. This is a cartilage, and it is a ring-like structure which is protecting the nucleus pulposus. The purpose of the discs are they act as the shock absorbers. They act as the shock absorbers, right? And now if you remember, this disc is avascular, and now they gain their nutrition from the end plates. So they gain the nutrition from the end plates. But what is important is whenever there is a lot of forces which are acting on this disc, they tend to create a rent, that they tend to create a breaks in the annulus fibrosis. And whenever this nucleus pulposus is always under pressure which is contained inside the annulus fibrosis. So whenever there is more pressure because of the rents or because of the gaps which are formed in the annulus fibrosis, this nucleus pulposus will try to escape from this gap, and whenever they try to escape, there is exactly the nerves which are entering into the foramen, and now they cause the indentation of the nerve, right? So they cause the indentation of the nerves because there is a spinal canal which is traveling just behind the disc, and from the spinal canal there are various nerves which are coming out. So this, when this particular NP, that is nucleus pulposus or the disc, now create pressure over this nerve, and depending upon the disc level, the nerve will get involved. The following nerve will get involved. So now let us see which nerve gets involved. So if you see this cross section, what is happening here is there are two important nerves. Always you have to remember that whenever you're talking about a disc, so this is an L4, L5 disc which we are talking, right? So this disc L4 and L5, if you see the exiting nerve, so this is the nerve which is exiting here. So at the L4 and L5 disc, there is an L4 nerve which is exiting and the L5 nerve which is traversing. Traversing meaning it is going through that particular disc. So it is traveling on back of the disc, right? So there are two important nerves you have to remember. One is the exiting nerve root and the second one is the traversing nerve root. The second one is your traversing nerve root. So L4, L5. At the level of L4, L5, usually the upper one. So the L4 will take the exit from that particular foramen. So this is the foramen. So L4 is exiting. But what is traversing? L5. L5 nerve root is traversing. And now remember, this disc will come and hit the traversing nerve root because already the L4 has left the foramen. What is the nerve which is present here? So L4 has already left the foramina like this. So what is traversing like this is hit by this disc. So usually the traversing nerve root will be at the risk. So here the traversing nerve root is your L5. So here the L5 nerve root will be affected. Understood? This is the concept behind which nerve gets affected. So usually the lower one. So similarly, if you see L5 and S1, similarly if you see L5 and S1, here what is happening? The L5 is exiting, but the S1 is traversing. So which nerve gets involved here? Is it L5 or S1? Is it L5 or S1? In L5 S1 disc, which nerve is getting involved? Very good. So that is the S1 nerve root is getting involved. So having understood so much, no, I want to just tell you one more interesting concept also. Don't, uh, curse me, because sometimes they keep confusing you. So here, whatever till now I have talked about is about the central disc prolapse. That means there is a disc prolapse in the center of the disc. So this area is getting affected. So this area is getting affected ka matlab there is an involvement of the traversing nerve root. But sometimes what happened is the foraminal, the disc at the end, I mean like the corner of the disc will get involved. So that will lead to foraminal stenosis. So that will lead to foraminal stenosis, right? So whenever this foramen is involved, then there will be damage to your L4 nerve root. Understood? Then the exiting nerve root will be affected. So exiting nerve root here is L4. So you have to always check whether the disc is a central disc prolapse or a foraminal disc prolapse. If it is a foraminal disc prolapse, then the nerve which is affected is L4. If it is central disc prolapse, it is L5. But usually in the exam, they will ask only about the central disc prolapse. 99%. But 1%, sometimes some examiner, because we have learned so much that only the lower one is involved, and we have made it so easy for the students. Now the examiner wants to understand whether whether the students have understood the concept or just simply mugging up. So if they want to understand the concept, then they might ask this question. So in L4 L5 disc prolapse, if the central disc is involved, then no doubt happily you can mark the traversing nerve root, that is the L5 which is involved. But if it is a foraminal disc, if the disc is involved at the ends of it, so this end or that end, not the center one, then there is a chance of L4 also getting involved. Is this clear? Any confusion? They confuse you? It's fine, Nitin. Clear? So now the answer for this would be, so what is the most common nerve root which is involving? Very good. So the answer here is L5. So if L5 is involved, then what are the areas where you check? So L5 will supply which dermatome? So you have to check for the grade 2. L5 is grade 2, and the first web space of the foot is also L5. So now what you do, whenever you have understood that the L4 L5 disc is prolapsed and you already know that the L5 will be involved, then you go and strike over the grade 2. You check for the extension of the grade 2, and then you check the first web space of the feet, sensations of the first web space. And now if it is decreased, then you see that the radiological and clinical correlation. So that is how you have to treat these spine patients. You have to check the radiology, and then now you have to check the clinically whether it is the L5 only is involved or not. Okay, that is the answer. So they might ask you L5, or they might ask you what to test. So you will test the extensors of the greater because that is supplied by the L5, or the first web space of the foot, that is by the L5. Okay, if it is was S1, then what do you check? If it was L5 S1 disc prolapse, and I told you that S1 is involved, then what are the areas you check for L1? I mean S1. So whenever there is S1, little finger, this is in the limb, lower limb. So okay, S1 is lateral aspect of the foot. He meant little toe. Okay, good. Toe region, the little toe region, lateral aspect of the foot. Okay. Now what is this? So we have learned so much about the pathology of the disc prolapse, and all this is in the mind. But how do you tell that the patient is suffering from disc prolapse? What is the clinical test? So what is this clinical test? This is straight leg raising test. So this is a straight leg raising test. And if you see, it is done by the surgeon himself. So this is a passive SLRT. So this is the test we do in the OPD, where we stretch the sciatic nerve because the sciatic nerve is present on the posterior aspect. In this test, what we do is we try to elevate the limb, and this limb on elevation with the knee in extension will cause the stretch of the sciatic nerve, and the patient will have pain at the level of less than 60 degrees of elevation. That is very important. If it is more than 60 degrees and now he is having pain, that is irrelevant. It should be less than 60 degrees, and on the lifting of the limb, if the patient is having some shooting type of pain, then it is an indication of a disc prolapse. Indication of the disc prolapse. So this is a passive SLRT used for diagnosis of your disc prolapse. Okay, clear? Then what is active SLRT? So passive is somebody is doing for us. Active is we doing by ourselves. And this is you ask the patient to lift with knee in extension. And this is used for diagnosis of the hip fracture. So sometimes we see the impacted IC fractures, right? So that means the IC fracture is present, but the patient is able to walk and is able to move. So for that thing to isolate, so we'll ask the patient to do active SLR. So we directly ask the patient to lift the limb in with the knee in full extension, so that if the hip is in continuity, she will able to do that. If hip is not in continuity, the problem in the hip, then they will fail to do this active SLR. So we can rule out the hip pathology in case of your active SLRT. Passive SLRT is fine. Active SLRT is for hip. Is this clear? Okay, good. Now what is this? This is a straight answer. You have to remember there are certain deformities, like in the hand you remember there is a bottinius deformity, and then there is your swan neck deformity, your Z deformity, and here in the knee there is a triple deformity, which is because of the flexion, posterior subluxation, and external rotation. This is very, very important. Flexion, posterior subluxation, and external rotation. Not internal rotation, it is external rotation. And this is seen in other areas of the uh, uh, other conditions also. How do you remember that? By the mnemonic triple. So it is seen in tuberculosis, rheumatoid arthritis, iliotibial contractures, polio, and hemophilia. So these are the conditions, the 1, 2, 3, 4, 5 conditions which you have to remember. And this is the triple deformity of the knee. So whenever you see the knee is in flexion, whenever the knee is posteriorly subluxated, that means joint has movement backward, and then there is an external rotation. You tell that as a triple deformity. And what are the other areas where you see for triple deformity? So you can see in tuberculosis, rheumatoid arthritis, iliotibial contractures, polio, and hemophilia. Is that clear? Very, very straightforward question. Sometimes they may directly ask you which of the following is not an indication, or whichever following we can't see a triple deformity. Okay. Then a 55-year-old female presents with a recurrent bone fractures and muscle weakness. So there is a bone fracture, but this is a 55-year-old female, and reveals there is an elevated serum and parathyroid hormone levels. Bone densities can show signs of osteopenia. She reports a history of kidney stones and GIT symptoms. Which of the following manifestations is seen? So you know that there is one mnemonic which is bone pains, renal stones, abdominal moans, and psychic tones. And this is a very classical description which is given in our very important book of pathology, that is Robbins, right? So this is a features of hyperparathyroidism. Okay, so the parathormone hormone increases, the PTH increases. So whenever there is an increase in the PTH, this is called hyperparathyroidism, and these are the symptoms of hyperparathyroidism, where there is an increase in the PTH. So there are various reasons for this increase in the PTH. It could be primary, secondary, tertiary, but the main important reason is there is a decrease in the calcium. So whenever there is a decrease in the calcium, it is a trigger for increase in the edge. So in that condition, all these things happen. The bone starts pain. There will be formation of stones, and there is a gastrointestinal symptom, that is abdominal stones, and psychic variation, the psychic tones. And this avascular necrosis is usually not seen. Osteomalacia is not seen, and this is not pain disease of the bone, but this is a condition which is called as osteitis fibrosa cystica, where there is a accumulation of the fluid into the bones because of the weakness. And now what happens is the fluid gets accumulated there, and it forms into a tissue. It's called the Brown's tumor. So because of that color, the breakage of the blood, the brown color, it's called the Brown's tumor. And because of it is present as a fibrous tissue in the bone, this is called as osteitis fibrosis cystica. It is a condition which is seen hyperparathyroidism. Okay. So the rugged jersey spine is seen in hyperparathyroidism, right? So that is the hyperparathyroidism. It is mainly because of increase in the PTH. So again, I've told you that it could be primary, secondary, because there is a decrease in the calcium. It could be increase in the H. Clear? So that is about the hyperparathyroidism. And usually here what they ask you is about this rugged jersey spine. Okay. Next, Which of the following clinical test is used to detect flexion deformity of the hip? This is very, very important. As we know, the MT-CAN test is for supraspinatus. This is the supraspinatus tendon. And Job's test? Job's test is for Latchman's is for ACL. Series minor. And now we are left with one, that is your Thomas test. So you have to remember that the fixed flexion deformity of the hip is one of the most important question which is asked, which is called the FFD of the hip joint. So you have to remember that the FFD of the hip joint is identified by the test which is called as the Thomas test. Okay. What is the Thomas splint? So this your Thomas splint. Where it is used? So there is an angulation here, and then there is a two rods, the outer rod and the inner rod. The outer rod will have an angulation. Okay. So this is the Thomas splint. Where it is used? Thomas splint is used in quicker. This is for femur fractures. So Thomas splint is the splint which is used for your femur fracture, for mobilization of the patient. So this, with this, what we do is we apply this Thomas splint and then we cover it with the roller bandage so that it gets immobilized, and now it can be used for transportation of the patient. So that is Thomas splint femur fractures, and this is Thomas test. So what is this Thomas test? How do you do it? The patient should be in a hard couch or supine position, and now this is the abnormal limb. So let us assume that this is the right limb which is abnormal and this is the left limb which is normal. And now what you do, you try to flex the hip on the normal side, that the left hip is flexed so that the thigh is touching the abdomen. So the thigh is touching the abdomen. So whenever you're trying to flex the normal hip, what happens is the compensatory mechanism. So till now what happened is, whenever there is a problem in one hip, the other hip will come to rescue, right? So because of the problem in one hip, there would be lumbar lordosis for this patient. So lumbar lordosis is exaggerated lumbar lordosis. So you can see a space whenever the patient is sleeping on the couch. Once you flex this normal hip, the spine becomes straight. So the compensatory mechanism is lost, and now the flexion deformity of the hip is seen. So this elevation of the thigh from the couch is the flexion deformity. So now you will put a scale here, then you put one more scale over the thigh bone, that is over the long axis of the thigh bone like this, and there is a one more scale like this, and this angle is your fixed flexion deformity, and this is done by your goniometer. Is that clear? So whereas any problem in the hip joint is compensated by the lumbar spine, as we have discussed in the scoliosis. So similarly, what we do is, here also we try to, whenever there is an FFT in the hip, there will be an exaggerated lumbar lordosis. That means, so lordosis is something like this, a curve. So this curvature get increased. So when this patient is sleeping on the couch, you see there is an increase in the lordosis. But once you flex the normal hip, this will become straight. So you don't see any gap here. And now when this gap is gone, when this flex, the original flexion will come. So this original flexion is the thigh will get lifted from the couch. So this is called the flexion deformity. So normally what should happen? Normally the limb should be like this, but it is going like this. So this is called the flexion deformity. And now how do you measure it? You put a scale to the couch and one more scale to the long axis of the femur. So how much it is elevated, you will know, right? So this angle is the FFT. So that is called the fixed flexion deformity, and this test is called the Thomas test. So this test is called the Thomas test. And not to get confused with the Thomas splint, as I've explained, that is for transport of the femur fractures. What is this test? Faster. Okay, we are coming to the end. What is this test? So this is the empty can test. So this test is the empty can test. This is for the supraspinatus. So if you remember the rotator cuff muscles, there are sit muscles like supraspinatus, infraspinatus, teres minor, and subscapular. So there are various tests given for the each muscle. So supraspinatus is mainly for the empty canter, right? And then you have teres minor, infraspinatus, and subscapular. So subscapularis, you have again belly press test. These two are important. Supraspinatus is empty can test, and this is your belly press test or bear hug. Belly press test or the bear hug test. So these three you have to remember. The test names, that is supraspinatus is empty can. You do like this and you try to lift. So this is your can and this is your empty can test. Okay, and belly press is nothing but to take two hands, put on your belly button and try to press them. So subscapularis is mainly for the internal rotation, right? So you test for the subscapularis, and teres minor and infraspinatus are both for the external rotation, right? So you try to test the lag test. So you try to do the external rotation and then you see whether you're able to do the external rotation test or not. Here, what is this? This is the Latchman. So this is the Latchman's test. So Latchman's test is for ACL, that is your anterior cruciate ligament. So anterior cruciate ligament is the Latchman's, and now you test for the integrity of the ACL. You hold the thigh with one hand and the leg with another hand. You try to move anteriorly. You try to move the tibia. If it is freely moving, that means there is no ACL. If there is a resistance to the free movement, then there is an intact ACL. So this you can identify by the Latchman's, and this is done in the acute conditions. So Latchman is usually done in acute conditions where you can see the limb is flexed only to 15 degrees That is 15 degrees of flexion. But there is one more interesting test, that is the anterior draws test, where it requires 90 degrees of flexion. So if somebody is asking you in acute conditions which test you do, that is Latchman's, because it requires only 15 degrees of flexion. And in non-chronic cases, you can go for your anterior draws test, where it requires 90 degrees. But the specific test for ACL, what is the specific test for ACL? Good evening, Aradhana. What is the specific test for ACL? So there are three tests we are discussing. So one is your Latchman's test. The second one was your anterior draws test. And what is the third test? That is a specific test for ACL. Nitin, you left? Yes, very good. It is the pivot shift test. The specific test is the pivot shift test. Very good. So these three are the important things which you have to remember. That is the Latchman's, anterior draws, and the pivot shift. And test for posterior draws is, posterior draws test is for PCL, right? So anterior draws is for ACL, posterior draws test is for PCL, and pivot shift test is for your ACL, which is very specific and it is usually done under anesthesia. And what is a sensitive test for ACL? Among these three, which one is called the sensitive test for ACL? Sensitive test for ACL? So Latchman is considered as the sensitive test for. So Latchman is considered as the sensitive test for ACL. Okay, the next one, 28-year-old male football player experiences weakness and numbness in his right arm and after the hard tackle. So there is a hard tackle for the football player and there is a weakness and numbness in the right arm. These symptoms have developed immediately after the impact but have gradually improved over last few minutes. On examination, there is a strength decrease in elbow flexion, but reflexes, sensations are all intact. Which of the following is the most likely diagnosis? So what could be the answer for this? Is it axonotmesis, neuropraxia, neurotemesis, or just a radiculopathy? What could be the answer? Yes, this is a neuropraxia. Why it is a neuropraxia? So whenever there are nerve injuries, there are three types of nerve injuries, right? So one is neuropraxia, axonotmesis, and neurotemesis. So neuropraxia is a temporary block. So there is a conduction block in case of your neuropraxia. Axonotmesis, there is a problem in the axon, right? So axonotmesis is nothing but, so there are the layers. So if you remember, the ectoplasm is covered by the layers. So there is a disturbances, there is some pathology, and that is the axonotmesis. Neurotemesis is cut in the nerve. right? So if you remember the layers, so first one is the nerve. So what are the layers? This is the axon and the flow is axoplasm. And now this is covered by myelin sheath. So these are the gaps. And now this is covered by the endoneurium, right? And then comes the perineurium, and then comes your epineurium, right? So these are the layers. So this is the epineurium, perineurium, endoneurium, and this is your axon. So whenever there is a problem in the endoneurium, that could be up to axonal, right? If there is a damage to the epineurium, then it is complete neurotemesis. So as they have told that there is a recovery of the symptoms, so this could just be a conduction block, hence the answer is neuropraxia. If it is an axonotemesis, they would be decreased in the flexion, and then there would be reflexes would be absent and the sensations were also be lost. Understood? So this is neuropraxia. And what is axonotemesis? As we have discussed, what are the two important classifications which you have to remember for the nerve injuries? One is, so this neuropraxia, axonotemesis and neurotemesis is based upon which classification? Name of the classification. Aradhana, name of the classifications. So the first one is the sedans. Second one is the Sunderland. Okay. Sedans has divided it into neuropraxia, axonotemesis, and neurotemesis. Sunderlands has divided into grades. So this is grade 1, 2, 3, 4 and 5, right? So grade 1 is nothing but it correlates with neuropraxia. 2, 3 and 4 is axonotemesis and fifth one is neurotemesis. Is that fine? So these 2, 3 and 4 is based upon this layers. So if the axon is disturbed, it is grade 2. If the endoneurium is disturbed, it is grade 3. If perineurium is lost, it is grade 4. And if epineurium, that is complete damage, then grade 5. Is that clear? So this is Sedan's and the Sunderland's classification of your nerve injuries. Next. A 40-year-old female presents with complaints of the hip pain and progressive difficulty in walking. On physical examination, there is a noticeable deformity of her femur described as a very classical description, that is shepherd's crook appearance, and radiological findings relieve a ground glass appearance with cortical thinning. What is this? So immediately as we see the shepherd crook deformity, the answer is fibrous dysplasia. So what is fibrous dysplasia? The marrow completely replaced by the fibrous. So that is why it is appearing as a ground glass structure. So now there is no strength in the bone. The cortex has become thinned. Now entire bone is replaced by the fibrous tissue, and it is called as your fibrous dysplasia. And there is a cortical thinning, and usually males. And what else you have to remember? It is usually seen as monostotic or a polyostotic. That means only one bone or multiple bones can be involved, right? So whenever there are multiple bone involved, what is the syndrome associated with the fibrous dysplasia? Very important syndrome, where it is associated with the cephaloid spots, precocious puberty, and fibrous dysplasia. What is this syndrome called? Vasant syndrome is called polyostotic fibrous dysplasia with cephaloid spots and precocious puberty. Quicker, I'm waiting for your answer. What is the syndrome called? Precocious puberty with cephaloid spots and related with the fibrous dysplasia. Very, very important. Are you people there? It's called the McCune-Albright syndrome. Yeah. So whenever you see this fibrous dysplasia, this is a Shepherd Crook deformity. So again, if you remember, now the bone has become deformed. So there is a problem in the bone where the deformities is seen, and sometimes there is also pathological fractures also. So the pathological fractures can also be seen, but this is the deformity of the bone, that is a Shepherd Crook deformity. Very, very important exam based question. And now this whenever it is associated with the cephaloid spots and precocious puberty, then this is called as the McCune-Albright syndrome. Understood? Good. And then what is this? What is this? This is osteochondroma. What is osteochondroma? If you can see, this is a osteo means bone, chondroma is cartilage. So there is a bone component and there is a cartilage component in it. So whenever there is a combination of both, it is just a bone mimic. The bone tumor mimic. So it mimics like the tumor, but it is not an actually tumor. So it is just an overgrowth of the bone because of some derangement in the growth plate. So there is some problem in the growth plate, so there is an overgrowth of the bone. So because the growth plate is also made up of cartilage, this is the bone which is present and it is covered by a cartilaginous cap. So this is the cartilaginous cap. So this is called as exostosis or else the osteochondroma. Understood? So this cap cannot be seen clearly on the X-ray, but here some of it is visible here, and this is the X bone. This is the bone pedunculated, and now this is covered by a cartilaginous cap, like okay. So usually on the X-ray it appears it tends to be smaller, but real it is larger because this cartilage cannot be seen, cannot be X. Good. And now this is to be excised or removed because it's an extra growth. Usually purpose, patients tend to get it removed. But sometimes it may cause disturbances, creating a bursitis, or they abut on the vessels, on the nerves, and that time they have to be removed, and they can be turned into malignancy, which is called sarcoma. As I've told you, chondro means cartilage. So the cartilaginous cap here, it is the dangerous structure. If it is growing, increasing in size of more than 2 mm, then you have risk of developing a sarcoma in it. Okay, so that is why you have to be careful and you have to remove this osteochondra. Is this clear? Then what is this? These are multiple swellings which we can see. So this is a cartilage tumor again. This is called as enchondroma. So multiple enchondroma is called as multiple enchondromatosis, or it is called the oleus disease, or it is called the oleus disease. Are you there? So usually these enchondromas are seen in the hands and feet bones. The small structures which are present inside, they're called the enchondromas, and multiple enchondromatosis is called the oleus disease. Okay, so multiple osteochondromas or multiple exostosis is called multiple exostosis. What is it is called? It is called as diaphyseal achalasia. So whenever there are multiple exostosis, so there are multiple exostosis. So these are all the examples of multiple conditions. So first, multiple fibrostosias can be there, multiple osteochondromas can be there, multiple enchondromas can be there. So this multiple exostosis is called as the diaphyseal achalasia, multiple cartilaginous tumor enchondromas, especially seen in feet disease, and multiple fibrous polyostotic disease is called as a McCune-Albright syndrome. So this is very, very important in case of orthopedic oncology. Okay. Okay. Decurvent tenosynovitis. Quicker. We will move little faster because I think you people are all tired. So decurvent tenosynovitis, we already know that the tenile sign is not usually for the these structures, because tenile sign is for the nerves, and we know the dugas, and these are for the shoulder dislocation. So we are left with only one thing, that is your Finkelstein's test. Okay, this Finkelstein's test is used for diagnosis of decurvents. Decurvents is nothing but where there is an involvement of first compartment extensor tendon, that is APL and EP. Here, abductor pollicis longus, extensor pollicis brevis. If you remember, there are six compartments, six extensors present in the hand. So the first compartment, which is supplying the thumb, is APL and E, that is abductor pollicis longus and extensor pollicis brevis. So when these two are preserved in one particular sheath like this, so this tendons are going in one sheath, that is one extensor sheath. So this sheath, whenever it get inflamed, now this tendons also get inflamed, and that is called as the decurvent tenosynovitis. So that tenosynovium, the sheath which is covering the tendon, gets inflamed. And this itis, whenever is present, will present with the pain. So there is a test which is called as Finkelstein's test. So Finkelstein's test is, you close this thumb, make a fist, and then try to extend. So whenever trying to extend like this, okay, stretch the tendon. So this stretching of the tendons will produce pain, and this is called as Finkelstein's test. So there is Cosen's, reverse Cosen's, Finkelstein's test. Is that clear? What is this? IBQ. What is this test? So this is nothing but your Dugas test. So what is Dugas test? Dugas test is nothing but whenever a patient comes with shoulder dislocation, what you do, you have to know whether it is really a shoulder dislocation or not, right? For that, what you do, you just ask the patient to touch the opposite shoulder. So if he is coming with complaint of the right shoulder dislocation, then you ask them to touch the opposite, that is the left shoulder. So if he is able to touch the left shoulder, that means there is no shoulder dislocation. Understood? So that is the Dugas test. So this is the Dugas test. So now, as we have learned with so many tests, let us fill up this block. Are you with me? So anterior draws test is for ACL, posterior draws test PCL, Latchman's it is for ACL, pivot shift as we have discussed it is ACL, and now you have to tell me what is McMurray's test. What is McMurray's test is for? Come on, I'm waiting. McMurray's test is for? It is for your meniscus. So we have two meniscus, right? Medial meniscus and lateral meniscus. Yes, very good. It is for the meniscus. Meniscus, medial meniscus and lateral meniscus. Both we are going to test it with this McMurray's test. Then what is Varus test and valgus test for? So Apley's grinding test is also for meniscus. So now what is varus and valgus? Very good. The varus and valgus are for collateral ligaments, and varus is for your lateral collateral ligament and valgus is for your medial collateral ligament. Excellent. And what is the dial test? Dial test is separate component. It is called posterior lateral complex, where it includes the posterior ligament, that means the PCL, the meniscus, and there is one more thing, that is your popliteus muscle. So these all structures they form together, which is called as the posterior-lateral complex. Okay, posterior and lateral structure. So that test is called your dial test. That is for your dial test. Just remember it as PLC. Okay, not PCL. PLC is for your dial test. And now valgus and varus is for your lateral collateral and the medial collateral. That is your medial collateral ligaments, and your McMurray's and your Apley's grinding test is for your meniscus. Is that fine? Good. Now these are all one-liners. What is the type 1 collagen usually not seen in? So we all know that collagen, bone is made up of collagen, ligament is made up of collagen, and aponeurosis is made up of collagen. But hyaline cartilage is 2, type 2. So the answer is D. So type 1 collagen is not seen in hyaline cartilage. What is this X-ray? This is very easy. We have seen cupping, fraying, and splaying. So we are seeing cupping, fraying, and flaying in case of the kids. So this is the rickets. Then bone mineral density screening should be performed in which of the following patients? So we already know that BMD is nothing but the test for osteoporosis which have been used in certain patients. So usually it is done in women of more than 65 years of age and men more than 70 years of age. But usually if these patients have any risk of fall or if they have any fractures of more than 50 years, also the BMT is recommended. The screening is given for certain patients. These patients has to be done. So it is usually done for women more than 60, men more than 80, and if there is any vertebral fracture or hip fracture above 50 also, you have to do this screen. Understood? So the answer is all the above. Okay, patient with history of RTA has come with the attending orthotides 3B. So whenever there is a 3B on his both lower limb fractures, according to Castillo-Anderson, what is correct? So you already know that the Castillo-Anderson's classification is for the open injuries, right? So whenever we see an open injury, we try to grade it according to the Castillo-Anderson classification. So we already know there are 3 grades which are present in it, grade 1, 2 and 3. So 1, 2 and 3, and mainly this is based upon the size of the wound. So if there is less than 1 centimeter, it is straight away 1. So whenever it is 1 centimeter means there is minimal contamination and minimal soft tissue damage. If the laceration is 1 to 10 centimeters, so it should be more than 1, less than 10. So that is grade 2. So here also there will be bone coverage will be more because it is less than 10 centimeters. But when it is more than 10 centimeters, it is again divided into A, B and C. So there is 3A, 3B and 3C. So 3A is one where there is a soft tissue coverage is present. B, there is no soft tissue coverage, right? And bone is exposed. And C is very, very easy whenever there is a vascular repair required. So vascularity is lost, it's straight away 3C. You have to decide between 3A and B. So what are the things which we see? So in case of 3A, there will be soft tissue damage, but you can manage it, manageable soft tissue damage. But in case of 3B, there is complete bone exposure with periosteal stripping where you require a plastic surgery support. So this is very, very important for diagnosis of 3A and 3B. So whenever you say it is 1, it is easy for you because it is less than 1 centimeter. 2 is also easy because it is less than 10 centimeters. But 3A, whenever there is a plastic surgery referral you require because there is a lot of bone exposure and then there is a lot of periosteal stripping, then that is 3B. But if this soft tissue damage is manageable by you, it is 3A. So here what would be the answer? So there is a 3B, they have written 3B. That means they have been asking for some soft tissue coverage. So there will be an extensive soft tissue damage with the periosteal. Is this clear? Castillo-Anderson classification, is it clear? Any more clarification you need? Okay, good. So now this is your open wound. And what is the treatment for the open wound? So this is the wound. Now we know we have to fix the bone. So we can't fix the bone with the implants immediately because there is a high risk of infection. So what we use? What is the other technique which we use to treat these open injuries? So what is that? This is called as external fixation. So we are fixing it from the outside. So this wound, we are giving the time for the wound to heal. So this is a rod which is used and these are the pins. So these are called the Schanz pins. So these are called the Schanz pins because they are in this variety. So there is threads only at the end of the pin. So this end of the pin will go into the bone. So this is your bone. And now we are putting the pins like this. So from the fracture, we put 2 pins. These threads will hold the bone for us, and now you connect this with the rods, right? These are the clamps. So these pins are taken through the rods by the clamps. So this is called the external fixators. Called the external fixator. So any open injuries, first you treat the wound, you clean the wound properly. If you can suture it, you will suture it. Then you put an X-fix. So for the by this X-fixation, what we do is we give little time for the wound to heal. Okay, and then we can convert this into permanent fixation. Clear? Next. A bodybuilder is taking steroids, creatinine presented with bilateral hip pain and unable to squat. On MRI, there is a marrow edema, subchondral cyst, flattening of the femoral head. X-ray shows crescent sign. So here we are very clear. So is the open injury is clear? Yes, very good. So the answer here is AVN. Very good. So avascular necrosis is a condition because of the decrease of the blood supply or the cutoff of the blood supply, the femoral head goes into necrosis. So whenever there is a necrosis, because of the seepage of the fluid, there were subchondral cyst which is happening, and then there will be flattening of the head, and then you can see what is called crescent sign on the X-ray. All these are features of the avascular necrosis. And because of the avascular necrosis, the patient is unable to do movements such as abduction, which is required for squatting. Right? So this is everything fitting into avascular necrosis. Patient is able to walk, that is why no fracture femur. On the X-ray, you don't see any extra, so this is not osteochondroma. And TB hip is not usually there because the crescent sign is there. Subchondral cyst is there. So TB hip, we see complete, damage to the uh, joint space. So joint space is completely damaged. So here also you can see that there is complete avascular necrosis of. So this is white color structure. So whenever something is necrosed, it appears sclerosis. Yesterday we have discussed sequestrum is a dense sclerostructure structure because it is a dead bone. So something is dead is white on X-ray. Remember that. Something is alive is dark on X-ray. This is specific for the X-ray. On the X-ray. So if you say that is avascular necrosis, that is a dead bone which you're seeing, that means it is completely white on the X-ray. And typically for avascular necrosis, what you see is it is the subchondral cyst. So you see the subchondral cyst and you see the crescent sign. So some small cysts like this we see, and then you see the crescent sign. So there is half moon shape like this. Sign is seen on the. Understood? That is about the avascular necrosis. March fracture we have already dealt, but we don't know whether it is head, neck, shaft, and the base. Can somebody answer? No, this is the base. I mean, sorry, the neck. Neck of the metatarsal fracture. Not the head, it is the neck of the metatarsal fracture. So this is your March fracture where you see the fracture is the neck. This is the head, neck, shaft, and okay. So please remember the neck part is the fracture area, and this fracture area sometimes you don't see the fracture, but sometimes what you see is the callus formation on the X-ray because there would have been fracture long back. The patient will neglect because it is a um, impacted fracture. The gap is minimal, so he keeps on walking even with the pain, and then he comes with this callus formation. So March fracture is neck of the second metatarsal fracture. So you should be very particular in such terminologies because these are very easy questions to answer. Okay, so next time when it appears in the exam, you're going to mark this as neck. Okay, next, what is this deformity? Identify this deformity. We have dealt with swan neck, we have dealt with bottinius. This does not appear these two, so it could be a mallet finger or a jersey finger. So what is it? So whenever you see something is in flexion, so that means the extension. We have already crossed the swan neck and bottinius, right? So this is a mallet finger. Mallet finger is something in shape of this, and there is a damage to the extensor tendon, rupture of the extensor tendon. So this DIP is going into flexion. DIP is going into flexion. So this is a mallet finger. So this is a mallet finger, right? And what is a jersey finger? A jersey finger is one where there is a damage to the flexor. So the FDP is damaged. The flexor digitorum profundus is damaged. So the flexion of the DIP is lost. Flexion of the DIP is lost. So that is jersey finger. So hold of the jersey. They will hold of the jersey. So because of that, they damage the tendon, that is the FTP, flexor digitorum profundus. Hence it's called the jersey finger. And mallet finger is lost to the extensor tendon. So whenever there is a damage to the extensor tendon, then there will be flexion of the DIP. The mallet finger. Clear? Next, what is the earliest sign or symptom of the compartment syndrome of leg? So compartment syndrome is very, very important complication of trauma and most commonly seen in leg in the adults, in forearm case of. So what do you think is the earliest sign or symptom? Very good. So the pain on the passive stretch. So this is the earlier sign or symptoms. So compartment syndrome is purely clinical diagnosis, as you all know, and you have to be very, very aware. The first thing the child or the adult give us the clue is pain on the passive stretch. So first one is excessive usage of analgesics, and then you will have pain on the passive. And pulselessness, remember, loss of pulses is the last one. Loss of pulses is the last. Okay, and tingling and numbness somewhere middle. So the answer here is pain on the passive stretch. Very good. This we have extensively described yesterday. So here the answer is. So what is this deformity? This is the cubitus varus deformity. And when do you see this deformity? Whenever there is a malunion of which fracture? Supracondylar fracture. So the malunion of supracondylar fracture. Very good. Malunion of supracondylar fracture elbow will result in this cubitus varus deformity. We have discussed in detail. What is this? Which fracture most commonly occurs falling on outstretched hand with a wrist in extension? So here we are discussing about the most common fracture. So yesterday we have dealt with all these. So we know what is Coley, Schoffer's, Bathens and Smith. So now I'm dealing with the most common with wrist in extension. So whenever there is an extension of the wrist, so they will fall like this. So it is most commonly the, yes, Coley's fracture. Very good. Next, what is the following most common sequel of traumatic dislocation of the shoulder? So we have to deal with dislocation of the shoulder. There are three types of dislocation: anterior dislocation, posterior dislocation, and inferior dislocation. Right? So these are the dislocations of the shoulder. And we already know the most common is the anterior dislocation. Right? And the posterior dislocation is usually seen in case of epilepsy, and electric shocks. So these two are classical conditions where we see posterior dislocation of the shoulder. Okay, classical dislocation we see in epilepsy and electric shock. So here what should be, there should be abduction and external rotation. So there will be abduction and external rotation for anti, right? So that is the mechanism of injury. And now the patient will come holding his hand, and the Dugas test we have learned, and then we have learned the Hamilton ruler test for shoulder dislocation, and then there is a 𝐒𝐿AI axillary circumference test. These are the three tests which are there. And how do you reduce? You do the opposite. So what you do, you first abduct and then you release it, then you adduct and internal, right? So it is T, traction, external rotation, adduction and internal rotation, right? So this is what we do for reducing the shoulder dislocation. But what is the traumatic sequelae? The sequelae is usually there will be recurrent dislocation of the shoulder. So once you reduce the shoulder, that is not sufficient. Always be recurrent dislocation of the shoulder. So that is the sequelae. So once you reduce it, now you put in immobilize. And this patient is always at a risk for recurrent dislocation, right? So that is the thing which you have to explain to the patient. So there is always a sequelae of this traumatic dislocation. And here what you have to remember is there are two important things which you have to remember. So one is Banker's lesion. Understood? So Banker's lesion is nothing but there is a tear in the labrum. So the labrum will be disturbed. So that is the Banker's lesion. The second one is Hill-Sachs lesion. Hill-Sachs lesion, there will be problem in the humeral head. So there will be dent in the humeral head. So these two are the complications for the recurrent dislocations or habitual dislocations. So you have to remember these two. One is Banker's lesion. The second one is the Hill-Sachs lesion. Understood? So, what is the traumatic dislocation sequelae? Please remember it is the recurrent dislocation of the shoulder. Please don't mind, I am going faster because it is already 6 o'clock. We started somewhere at 3 and this is 3 hours. I know you all will be feeling bored, tired, irritated. So, I am just brushing up, okay? Which of the following is true regarding the Galeazzi? This yesterday we have discussed intramembranous tear with ulnar. So first, what do you remember by Galeazzi's fracture? So Galeazzi's fracture, what you remember? This is a radius fracture. So radius fracture means proximal or distal. So we already know that Monteggi and Galeazzi is a fracture dislocation. So we have to remember that this is a distal radio-ulnar joint dislocation. So radius fracture plus distal radio-ulnar joint dislocation. At the distal end of the radius, you will find a component which is called as TFCC, triangular fibrocartilage structure, which is usually present in the DRUJ area, this area. So ulna area, that is called the TFCC. Okay, so now let's see the radius fracture. So this is not radial collateral tear, that is not there. Okay, this could be intraosseous membrane tear with TFCC tear and a radial shaft fracture. So the answer is D. This is not ulnar shaft fracture also. So the answer is D. So you understood. So sometimes what happens is even though you know a lot of concepts. So we have yesterday we have discussed in detail that the Galeazzi is radial fracture plus the distal radio-ulnar joint disruption. But you have to be careful that the TFCC is what it forms the DRJ. Understood? So triangular fibrocartilage complex is TFCC, which is present, a structure which is present here, and it is mainly present on the ulnar side. So whenever patient is having ulnar side problem, so if you see in yesterday's x-ray, you can see that the ulnar styloid has come behind. This was the radius and the ulna has come behind. So because of that movement of the subluxation of the ulna, the TFCC gets in. So here there is a problem with the TFCC and there is a radial shaft fracture. So that is your Galeazzi fracture. Clear? Any doubts regarding this? Nitin, I have really lost the momentum here. I mean, like, what is A, C, A? I don't know for which question is that. Okay, are you clear with this Galeazzi fracture question? Give me a thumbs up first. Okay, good. Now, next question. A 4-year-old boy fell on outstretched X-ray. So this we have dealt yesterday. So which vessel is most commonly injured here? Come on, this I need to answer. Is it ulnar radial brachial cubital vein? Hmm. Yes, very good. The brachial artery. Yesterday we have discussed in detail about the brachial artery. So this is the diagram. So here what happens is depending upon the displacement, if it is displaced this side, so brachial artery and the median nerve is involved. So this is the medial side. So similarly, if it is on the lateral displacement, then there could be a radial nerve damage also. But most common is this. So that is why AIN more common than median, most common than ulnar, then it is the radial nerve. Okay, that is AMRU, what we remember it as. So it's a supracondylar fracture. So usually the artery which is damaged is the brachial artery. What is this? Identify the abnormality in this radiograph. Yes. What is this problem in this X-ray? Yes, very good. This is Boxer's fracture. So what is Boxer's fracture? Boxer's fracture is fifth metacarpal neck again. Fifth metacarpal neck fracture. So here if you see there is a fifth metacarpal neck fracture which is there and this is called as the Boxer's fracture. Then what is Kienbock's disease? Kienbock's disease. So Kienbock's disease is lunate avascular necrosis. Okay, so we have avascular necrosis like for femoral head, it is called as the Perthes disease, if you remember. Femoral head, it is Perthes disease. So Kienbock's is lunate. For capitulum is Panner's, right? And remember any more? Navicular polar. Iceline scaphoid is Priscius. Fifth metacarpal is Iceland's disease. Metatarsal. Second metatarsal is Freiberg. So these are all the avascular necrosis. Uh, these are various, conditions which you have to remember. Kienbock, just remember this as lock and key. Okay, lunate and Kienbock's. Capitulum is pancard, like panners and capitulum. Navicular is like Virat Kohli, Kohlers. Navicular is Kohlers. And this, I've just remembered scaphoid precursors and second metatarsal Trebergs and fifth metatarsal is Iceland's. Okay. Treatment for Kienbock's. See, Kienbock's is nothing but this is an avascular necrosis, right? So AVN, something we have to deal either by putting the graft or you have to remove that part. So it is a very complex procedure. So treatment of the Kienbock's, the lunate is a very, very important part, right? So we go for carpectomy, proximal carpectomy, or we treat it with graft. There are various treatments which are there, but it is usually not done, and it is usually a rare disease. But whenever something is avascular necrosis for Perthes also, what we do is we try with the osteotomy. So we do the osteotomy, we change the angles so that it regains its original shape and size. For Kienbock's, what we do is carpectomy, that is proximal carpectomy, or we try to put the graft. So sometimes it works with the graft, vascular grafts we put. That is a treatment for avascular necrosis. Clear? मैम फीमेल ऑर्थोपेडिक इतना कम क्यों होती है? Because it is like the female usually, see, the first thing, it starts right from the branch of trauma. It is not orthopedics, it is usually trauma where you need 24 hours, availability, which is difficult for the female. And next, the type of diseases we deal with them are usually, you have to do a lot of reductions, you have to lift the limbs, you have to put the slabs and casts where a lot of physical strength is required. So maybe because of that, most of them doesn't choose to do ortho, because there are other branches which are easy, which are, good and even more interesting for females. Okay, so coming back to the boxes fracture. So this is the boxes fracture we were discussing. And for this boxes fracture, what we do is, this is the KYS we put. So KYS we put, and this KYS will treat the fracture. So this was the, these are the KYS. So multiple, they have put two KYS like this. Okay, so these are the treatment for the KYS. What was my motivation for taking ortho? Because I used to love doing a lot of work. Like, I used to enjoy doing work instead of sitting. Most of my friends used to sit and read, so they have got into medicine and all. I used to do a lot of work like putting cast and slab, shifting them to OT, and then, you know, checking for the implants and all. It is a lot of mechanical work. And somehow I enjoyed it in my internship. So that is what I've thought, maybe give a try. What is this? What are the all of the following are true regarding the picture except? So this, as you see, there is some deformity here, right? So there is some deformity here, and this deformity is mostly seen on the dorsal side. So what do you think is this fracture? So this fracture, what do you think is this fracture? Except commonly fallen outstretched hand. So yeah, this is a Colles fracture. Very good. I agree. This is a Colles fracture. So it is fall by outstretched hand. It is correct. Non-union is a common complication associated with the Sudex osteodystrophy. This is also right. Sudex osteodystrophy is a condition where there is some damage to the autonomic nervous system, and patient will have severe pain. And after reduction, wrist is in neutral position, and what deviation they have given? But it is not in neutral position for sure. And here the non-union is not a common complication. As we have discussed yesterday, it is extra articular fracture. So the most common complication for this is, what is the most common complication? Yes, that is malunion. So malunion is most commonly seen, not non-union. So the answer is B. And here what we do, we apply the plaster in flexion and ulnar deviation. Okay, so not in neutral position, we do flexion and ulnar deviation. So we apply the plaster. Okay, so here this deviation, whatever is given, is gone behind the image for me here, but definitely not in neutral position. So we do a slight flexion, wrist slight inflection, and then in ulnar deviation. Okay, so the answer here is non-union is a common complication. That is wrong. Malunion is the common complication. Okay, what is this? So we have discussed this also. Commonest complication of this is recurrence, which is true. Very common in children and rare in adults. It is not striking and hence may be overlooked. No, the clinical features are very, very striking. You can see it has become straightened. Patient will have severe pain, and ulnar nerve is most commonly injured. Which nerve is most commonly injured in shoulder dislocation? Axillary nerve. So this is the axillary nerve which is most commonly involved. So they are asking you the true answer. So the true answer here is commonest complication is this recurrence. So we have discussed just before that the recurrence. So you see there is most of the cases what happens is they come with recurrence of the complications of the shoulder dislocation. And we have dealt with the anterior dislocation and the posterior dislocation. And what is the sign of posterior dislocation on the x-ray called as? What is the sign called on posterior dislocation? Yes, axillary nerve regimental badge area. Very good. So what is the sign of posterior dislocation? This is called as the vacant glenoid is seen in both, right? In anterior and posterior also. But in posterior dislocation, this is called as the light bulb sign. Okay. And I have told you that usually this is seen in the epileptic patients or in the electric shock, right? So that is about the posterior dislocation. Very good, light bulb. And what is this? These are the complications of the recurrent shoulder dislocation. What this picture depicts? What? Bhargavi, this is called the Bankerts. What is Bankerts? So there is a tear in the labrum. And which part of the labrum? In the anterior, inferior, area, right? So this is the area where usually the head keeps coming out. So the head keeps coming out and it's going in, keeps coming out and it's going in. So there is a disturbance in the labrum. So there is a disturbance in the labrum. Labrum is that cartilaginous structure which is present around the glenoid. So if this is the glenoid, just assume this is the glenoid. All this structures is the glenoid, this is the whole. Now, to make this as more hollow, what happens is there is a cartilaginous structure which is covering over the glenoid. So if this is your glenoid, there is one structure, there is this structure which is present around it so that the ball stays happily inside the glenoid. So this structure is nothing but your labrum. So this orange structure is your labrum. So whenever the now what happens is this sits nicely inside this. So the humeral head sits nicely inside this like this. But whenever it is coming out on habitual dislocations, this will cause tear in this labrum. So this will call tear in the labrum, right? So this tear in the labrum is called as the bunkered sleeve. And what is this? So here, because the humeral head is moving outside and inside on the posterior aspect, posterior lateral aspect, you see there is a defect in the humeral head. This is called as the Hill-Sachs lesion. So all H together. So humeral head for Hill-Sachs, H for H. Okay. What you have to remember is this is the posterolateral aspect and this is your anterior inferior area. The Bankards, this is the humeral head. Is this clear? So these are the two important complications of recurrent shoulder dislocation. And how do you identify? You go for an MRI and you go for arthroscopy repair. Shoulder arthroscopy. Okay. Yes, investigation of choice. Investigation of choice to identify these lesions is what was your, yeah, oh, that time it was not our all India ranking for us. I am from Andhra Pradesh, so we had this APPG, that is our state exam, and in the state exam I got somewhere around 860 something like that, and then I chose ortho. Thank you. Okay, what is the eponym of this fracture? Yes, this is Montegia. Very good. This is Montegia. Why Nitin is not answering? Montegia, this is fracture of the ulnar shaft with radial head dislocation. So proximal radio-ulnar joint is involved. So this is your, yes, thank you Nitin. So this is Montegia fracture. What is Jefferson's fracture? Fracture of? Very good. Fracture of C1 vertebra. C1 is like the arch. And if you remember, this is like the arch. And now what you have to remember is this is bilateral fracture of this. There's a fracture here, fracture here. That is Jefferson's fracture. What is Hangman's fracture? Hangman's fracture is traumatic spondylolisthesis. Traumatic spondylolisthesis of over. Okay. So this is traumatic spondylolisthesis of fracture of C1 over C2 and Hangman's fracture, that is, and then Jefferson's fractures is C1. Very good. Hangman's is two words. So remember C2. Jeff. Jeff, there are two F's, right? So it is a C1 fracture. What is the splint? Archana Aradhana. Yes, this is Dennis Brown splint. What is knuckle blender splint used for which nerve? Public harness is used for? Yes, it is traumatic spondylolisthesis of C2. Very good. Aeroplane splint is used for? Brachial plexus. Yes. Then public harness is for? So a patient with DDH of less than 6 months, the treatment of DDH is? Pavlik harness. Von Rosen splint and Pavlik harness is both for your TDH. Aeroplane splint is for brachial plexus. Knuckle blender splint is for your radial nerve. Then cock-up splint is for your, yes, cock-up splint is for, cock-up splint is for, yes, radial nerve. Good. Okay, now let us learn about a little bit of CTEV. So CTEV is congenital talipes equinovarus, and that means congenital. So congenital is by birth, and tally pes is tally and pes. Tally is what? Ankle, and pes is foot. Equino means it is like the horse foot and varus. So these two are the deformities. So plantar flexion equino and varus of the foot. So these two are the deformities in the ankle and the foot. So that is the meaning of congenital talipes equinovarus. What happens here is all the posterior medial structures. So the structures which are present on the medial side and the posterior side, they get contracted or they are underdeveloped. So because of this underdevelopment and this contraction, the patient will have a varus deformity and a equinus deformity. So that is the meaning of your CTEV. Now what do we do in CTEV when we identify the CTEV? So first we do casing. This is called as serial casting or casing. Serial casting is done for at least 7 to 8 weeks. You change the plaster for every week. So the patient has to visit every week. And how do you do it? We use the technique which is called as Ponseti method. So how do we treat it? The Ponseti method is cavus, adduction, varus, and equus. So this is how we treat. So what are all the deformities we see? So first we see cavus. Cavus is seen in midfoot, right? So what is cavus? So the arch is exaggerated, that is cavus. And adduction you see in the forefoot. So all the metatarsals will go into adduction. And varus, where do you see? Varus is seen in calcaneum, that is your hind foot. You go for varus. And equinus is seen in the ankle. So what is equinus? In the ankle, that is your plantar flexion. So this is your plantar flexion. So these are all the deformities which we see in case of CTE. Right? So cavus, adduction, varus, and equinus. So how do you correct it? So first you try to correct the cavus, then you try to correct the adduction, then the varus, then the equinus. So all this is corrected by serial casting in 6, 7 to 8 weeks by your POP. So this is how you put it. You put this POP above knee. Okay, so this is the deformities and this is the correction. So what is this angle in CTEV? Yes. Hi, Bharat. So this is 𝐼𝐾𝐝's angle. So this is 𝐼𝐾𝐝's angle. So here what is happening? 𝐼𝐾𝐝's angle is parallel. So this is called parallelism in CTEV, where you see both the talus and the calcaneum longitudinal lines are parallel to each other. Okay, these are parallel to each other. Normally, they will form an acute angle. Now they have become parallel. So this is called 𝐼𝐾𝐝's angle in CTEV. Now what is this? This we have already answered. So once we have done with the plasters, then we put the baby in the Dennis Brown splint until he attains the age of walking. So for 24 hours for 1 to 2 years, and then we go for 12 hours. Fine. And once CTV, it becomes normal. I mean, it becomes zero. That is what is parallel, no? And what is this? Once the baby attains the walking age. So this walking age is attained, then we prescribe this CTE, prescribe this choose. So the importance of the choose is you can see that there is a straight border here. So inner side there will be a straight border and there is an outer ray. So why inner side is straight borders? To avoid the cavus and adduction. And outer side again it doesn't go into cavus and adduction, right? And the heel should be completely flat. So already the patient is in equinus, so there should not be any equinus. So there is no heel to prevent equinus, and outer side is raised because already it is turned like this, right? The foot should be like this, it is turned inside. So again, if you don't raise the outer edges, so outer edges usually raised so that it becomes flat. Understood? Bharat, that is 20 to 40. I think you were talking about the bowler's angle in calcaneum. Outer raise and then straight. So this is all to correct the deformity so that it doesn't recur again. So this is about the CTV. God Kumar will see 60K rank to 2K. We what what is that you have to do? You have to read every day. You have to read, do MCQs again. You have to see by yourself where you stand in the race, and then you have to uh, again read where you are lacking, and again write the exam. See, there is only one way to achieve your goal, that is hard work, determination. That's it. You have to be determined and you have to do the hard work. That's it. Nothing else should come in midway to stop reaching your goal. There is no tips, there is no shortcut, there is no mnemonics, or there is no any specific institute which will make your dream achieve. You're the only one you who can do that. Okay, so you have to plan accordingly, customize your plan based upon yours. Okay. So your first thing should be there, be in this moment. Now we are reading about ortho. So let's complete the ortho questions. Let you be active in answering them. Okay, this is not the topic of discussion now. Okay, so that is about the CTV. All you have to understand and learn. Is that clear, everyone? Very, very important. So the important thing is you have to understand what are the various deformities which are present in CTV and how they're corrected. So this is the Ponseti technique which you are correcting, and this is by achieved by the serial casting, right? So serial casting you have to do and achieve this cave. Fine. What is the diagnosis? It is a clear cut IBQ. We have discussed it so much yesterday. Yes, GCT. Bharat. Yes, very good. Very good. Next. A patient came with complaints of inability to move fourth and fifth digit, so that is the little finger, cannot hold the pen and was unable to hold paper between the fingers. So they were talking about the card test, if you remember. So card test and fourth and fifth digit, which nerve are they talking about? So they are talking about which nerve? So that is your ulnar nerve. And now you tell me what is the answer of this? Yes, this is the medial epicondyle, the lateral epicondyle shaft, and the head of the humerus or the proximal humerus. So you can feel the ulnar nerve at the medial epicondyle, and sometimes there would be problem at the medial epicondyle and the ulnar nerve can be damaged. So this will result in CART test positive and the problem in your fourth and fifth digit. Very good, Nitin. This one, I want Bharat to answer this. Yes, he's unable to flex his index finger, that is the median nerve. Very good. So median nerve is mainly for the index finger. Yesterday we have discussed this. So this is nothing but your pointing index. So the answer is median nerve. This one, yes, radial nerve. So what fracture is this? This is Holstein-Lewis fracture. This is Holstein-Lewis fracture. Very good. Excellent. This one, yes, very good. This is a partial claw hand. We have discussed so much in detail yesterday. So the answer here is the ulnar nerve. This is the partial claw hand. What is the answer of this? So what is this canaveral sign? Yes, correct. So canaveral sign is nothing but the inflammation of the tendon sheath. So if you remember, these are the tendons, the flexor tendons, and these tendons are enclosed in the tendon sheaths. So these tendon sheaths, whenever they get inflamed, they produce this canaveral sign. So what are the canaveral signs? First, there will be pain, then fusiform swelling. So there will be a uniform swelling of the fingers, and then the fingers will be in flexion, and then they have pain on extension, right? So these are the four signs which are called the Calavan sign, and this is supposed to be the point of the tenderness where you can feel the tendon sheath. Fine. So here the answer would be pain on passive flexion. So here the answer is pain on passive extension. So all these are correct except C. Is that clear? What is the treatment for a patella fracture? Yeah, they will be in flexion. Whenever you see the tendon, the fingers, because of that tendon sheath, they will be in flexion. But when you try to extend it, they will have pain. So the answer here is canaveral sign. The fingers are in flexion, they are tender and painful, and there is a uniform swelling. So pain and passive extension, except. Okay, Aradhana, is that clear? Which of the following is a treatment of patella fracture? Yes, Nitin, you're right. This is tension band wiring. So this we treat with TBW, that is tension band wiring for a patella. So patella is what type of bone? Patella is a sesamoid bone, right? It is a sesamoid bone. And whenever there is a fracture, it is very, very important for extensor mechanism of knee. So patella is an important bone in extensor mechanism of the knee. So whenever there is a fracture of the patella, what we do, we put a cylindrical cast and then we treat with this 2K wires an SS wire which is called as tension band wiring. What are the other areas where we deal with tension band wiring? This can also be done in tension band wiring can also be done in medial malleolus, olecranon, greater trochanter. Remember. Very good, Bharat. Olecranon, patella, lateral malleolus, and greater trochanter. Very good. Super. So that is the answer for tension band wiring. So be sure that sometimes they may put medial malleolus also. So the answer would be tension band wiring. So what is actually tension band wiring? So because if you remember, so this is the tendon here, quadriceps tendon, and this is the patella tendon here. What happens is whenever there is a fracture here, this tendon will pull this fragment upwards, this tendon will pull this fragment downwards. So now what we do? We do this tension band wiring so that everything is into one structure. So we are compressing the fracture. So what actually is the principle of tension band wiring? Converting tension forces, that is pulling forces, into compression. Understood? So this is the principle of tension band wiring. So before it was tension, so it's pulling upward and downward. Now it is combination, like we have combined the two fragments, so now this will act as a one unit. So we are converting the tension forces into compression forces. Yeah, Bharat, today you're late. That's fine. We missed you so much, but that's fine. Next, what is this diagnosis? Yes, anterior dislocation. Very good. So this is anterior dislocation because it is in flexion. This is flexion, adduction, and internal rotation, right? So the diagnosis here is posterior hip dislocation. Not Faber. How it is Faber? This is the traumatic one. I mean, this one, not this. You can see the injury here. This is flexion, adduction. It is inside. Yeah, farther. Flexion, adduction, and internal rotation. So the answer is posterior hip dislocation here. The abduction is wide opening like this. Adduction is inside. So you see this limb is inside, no? This, go home and you sleep in the lithotomy position and then you put this is inside. So it is internally rotated and adduction. Faber is flexion, abduction, and external rotation, right? So external. This is externally rotated. This limb, if you see, this is somewhat externally rotated, but this is internally rotated. If you see, the patella is inside this way. So this is farther flexion, abduction, and internal rotation. Not convinced? Clear? Okay. Okay. Thank you. What is the attitude of limb in posterior dislocation of the hip? Flexion, adduction, and internal rotation. Farther right, flexion, adduction, and internal rotation. Very, very important hip joint. So the answer is D. Yes. What is this? The abnormality can be explained by the weakness of, so there is a dip on the right side. If you see, there is a dip on the right side. So what would be the answer? Very good. So gluteus medius is the answer. So dip on the opposite side. So this side is weak, there will be dip on the opposite side. So you have to remember two abductors. So gluteus medius and gluteus minimus. These two are the important abductors. This is called the Trendelenburg test. So you see dip on the right side, that means the gluteus medius on the left side is abnormal. Clear everybody? Any doubt in this? What is this? Answer for this? Bharat, answer this. Yes, very good. Sequester. So what is B? Yes, B is 𝐒𝐿. Very. What is C? Oh, C we have already answered the sequestrum. No, what is A? Yes, A is involute. Perfect. Okay, that's it. We have completed it. Thank you so much, especially Nitin, Bharat, Aradhana, for attending today's class. So that's it for today, and we have completed in ortho in great detail. We have done 3 hours and 4 hours today. So any queries you want to reach out, I am available on Insta, that is Dr. Alekhya Ortho. Okay, can you explain the X-ray? What was that communicated that thing? So that was a communicated, that was again an open injury, right? So it is an open injury with communicated distal femur fracture, right? And this distal femur is severely comminuted. That means it was a very violent injury and it was intra-articular. So this is what I was expecting to answer. So whenever something is intra-articular, it gains its importance because the joint movements can be affected. So the joint movements can be affected. So if something is intra-articular, we need to treat it very vigorous. So the answer for that is the comminuted distal femur fracture, which is intra-articular extension. And because it was an open injury, that time we couldn't do the implants directly. So for this, what we do, we try to plate it. So you already know that whenever something is intra-articular, if something is around articular region, we do plating, right? If something in the diaphysis, we go for nailing. But on that day, we are unable to do these two because of the open injury. So what we have done, we have put the X fix. So we have done wound debridement, and then we have treated with external fixator. Now 2 weeks. Now after 2 weeks, what we do, we will remove this X fix and we will do the plating. That's it. I just wanted to answer you that it was a community, not a stable. Somebody has answered it as stable something. It is highly unstable because it was intra-articular, and you should also be aware of the ligament and the meniscal tear also. That is what I'll send you that X fix photo in the. Any doubts? So this is my Insta ID, and if you want anything to be personally learned, or you want any queries to be answered, you can text me on this. Is that fine? Any other queries you have? Bharat, I hope you're not yet convinced with the father. Okay, so that was adduction and internal rotation. So any other doubts you have, you can text anytime or come in touch with our team also. So wish you all good luck. Please do read well, do write well, and come out with the flying colors, and let us know how did you excel in the exam. See you all. Bye.